If a witness objects to answering a question, they should state the ground on which the objection is made, and the committee will determine whether it will insist upon an answer, having regard to the ground on which it is claimed. If the committee determines it to insist on an answer, a witness may request that that answer be given in camera. I also remind senators of their obligations under the Behavioural Code of Conduct for Australian parliamentarians to treat witnesses with dignity, courtesy, fairness and respect. Finally, I remind committee members and witnesses who are appearing remotely, if there's anyone there, to mute your microphone when you're not speaking, and remember to unmute. I've failed that myself a number of times, so we won't hold you to the strong penalties on that. I now welcome Dr. Stephen Gawley from the Australian College of Emergency Medicine. I understand that information on parliamentary privilege and giving evidence to committees has been provided to you.
Correct.
For the Hansard record, will you please state your full name and capacity in which you appear today?
My name is Dr. Stephen William Gawley. I am the immediate past president of the Australasian College for Emergency Medicine.
Thank you very much. Do you have an opening statement you'd like to make?
Just to sort of say that I'm also the clinical director in Alice Springs. I've been there for 19 years, so I'm coming to this with a reasonable amount of rural experience. I've also been the deputy chair of the National Rural Health Alliance and the chair of the NT Clinical Senate.
Okay. That's all you'd have? No experiences you'd like to?
Just a few things to put out there. So what I'm trying to inform is just it's coming from a broad base, not just emergency medicine.
Okay. I might kick off with a few general questions. What we're seeing is Medicare and the activity-based system working where it's a well-populated area where there is a market, where there are numerous medical outlets and stuff like that. What are you seeing in regional areas where that model, built for the vast majority of the population of Australia, but not the area of Australia, how is that working out there?
Yeah, it's problematic. One of the big challenges is just the same visit done in a city just simply costs more in a regional area. Transport costs, when you're ordering things in, something simple like putting a cannula in, which we do quite frequently, may cost X number of dollars in the city, but just because of the transport costs, getting them all there in storage that you need to have, it just costs more, and that's not really accounted for in the Medicare billing.
Right. What about sheer access? You say you're doing stuff around Alice Springs. You're in emergency medicine. How does that go? What's the delivery time from injury or from accident to getting to emergency? What does that time do to patient outcomes?
It's a real challenge. So for Alice Springs, we cover 1.26 million square kilometres all around.
1.26 million
square kilometres, yeah. For which a lot of very remote communities. And our major referral centre is Royal Adelaide. So we send a lot of patients down there. The timing can take quite a long time. So depending on where they are and what resources we have available, because we only have a couple of planes that we fly people in and out with, it can take 6 or 7 hours to get someone into definitive care. Okay.
There's been lots of talks about how regional areas might coordinate, might work together between different allied health, UCCIs, all these sorts of things. You talk a formalisation of that in your process. What would that look like?
So I think the Territory actually has a reasonably good example of this. So we've been using remote area nurses with a extended scope of practice for decades, and it's a model that works very well. It's complemented sort of supervised by medical staff. So we dial in and talk to the nurses there and provide treatment advice while we're also organising a team to go and get them and retrieve them into Alice Springs, start the treatment there, and then move out if required. That model is pretty common throughout Australia. It's one that works, and it's certainly not new.
Yep. But your submission does say about formalisation of it. You think it should be just ticked off as a standard practice, best practice across?
What we're trying to do, what we'd like to see with this is we need to make sure that the medical model stays intact, so that there is some medical oversight of patient as they come in and out through the door. So with extended scope of practice per se, we have found, we are able to keep people in community a little bit longer with good quality, like well-trained nurse practitioners and remote area nurses. It's just a matter of making sure that there is some oversight. So there's some medical decision making there as well. One of the things that we do through the Emergency Medicine College is we run a program called EMET, the Emergency Medicine Education and Training Program. basically go use that to take rural. It's a hub hospital concept. So the regional hospital will go out to the really small clinics out there and provide education and training. The real benefit to that is getting to know the practitioners in that space as well. So as you do the teaching sessions and you develop those relationships, you sort of know who you're dealing with. So when they phone the emergency department, speak to one of us, we know who we're talking to and what their skill set is, and because we've been out to their clinics and been out to their hospitals, we also know the resources that are there. So what we found with this program is we're able to give more targeted advice, keep people out in community longer or in the regional hospital longer if it's appropriate to do so. So rather than just bring everybody in to work them up, because of those relationships that have formed, you can more confidently keep people out there safely.
So that familiarity breeds a context of what's going on just because of the more integration, one would say.
Yeah, and it fits with what everyone's been saying for a very long time. It's the team-based approach. We're very keen to keep and develop that team-based approach. So one of the challenges is, because I've been thinking about this a lot, what's the role of a doctor in the system? And what we're trained to do, what I've landed on, is that we're really sort of the diagnostic sieve, So common things can present atypically. So you can see a lot of people with what sounds like the flu, but one of those may have meningitis, which is potentially life-threatening. So it's a matter of how you develop that skill set to do it. And it takes time to develop that gestalt. So you need to see 1 million people to be able to pick that group. Well, they say 100,000 hours of practice to become an expert in anything, and that's what we do with this. So maintaining that team-based approach, so right, you're fine with this, you're fine with that, or this one sounds a little bit trickier and we need to bring them in. So as an emergency college, we're very keen on keeping a team-based approach.
My wife was Max Fax in NHS in UK in A&E, and is a dentist now in Australia. And she always goes, the common things are common, but the uncommon are fantastic. And she gets excited when she gets a different thing. So I know what you're talking about. Yeah. She especially loves her jam and custard moments, but that's a different story.
Oh, it's a similar sort of thing. So, like, you'll get a phone call from a RAN that you know really well, and they're saying, this got abdominal pain, I'm confident it's probably just a urinary tract infection. You sort of ask a few questions, you go, totally comfortable with your management, off you go, no problem. Sometimes you'll get a phone call and say, I don't really know what it is, or they run through and you go, something tweaks with you, and you go, that doesn't sound quite right, we should bring them in. With a good model of team-based approach, which we're keen on, that works really well.
Yeah. Cool.
Yeah, I've got a question.
Thanks,
Chair. Doctor, a couple of things, and I'm very keen to tease out and get your view on this. And I had the pleasure of attending one of the urgent care clinics in Perth, not rural, but I have been at one in Broome and that. So with your experience and all that, what is your view? What would the perfect unit look like in remote, rural and regional Australia?
We have an urgent care centre in Alice, weirdly. A couple of things about urgent care, and thanks for raising it, is one, urgent care is, anything that improves access to care is a good thing, and we're very supportive of it. They're popular and they're filling a need. I think they're a really important part of the developing landscape, so definitely keen to keep them going. One of the challenges for us, for an emergency department, is that the people that are seen through urgent care, by definition, aren't the ones that are really causing problems in the emergency department.
Sure, yeah.
So what we're seeing there are people that need to be admitted, which are having troubles accessing the inpatient care, in getting into those inpatient beds. So urgent care centres aren't really doing much to improve our lot, but we wouldn't want to see them disappear. They're taking a little bit out of the waiting room.
You wouldn't want to see them disappear?
No, I think they're useful. They take a little bit out of the waiting room for us, but not a lot. And they're not really helping with our access block, so that's a totally different issue. So it's concerning when you sort of see that urgent care is a solution to access block, because it's not, and we're not seeing that. But but we're also very supportive of them because it improves access to care. What would it look like in regional Australia for us is the after-hours access. They definitely need to have the ability to do your basic X-rays, your basic procedures in being able to manage basic factors, and point-of-care testing, we're using a lot of that at the moment. So the clinic needs to be able to run some basic tests like a troponin or a basic sort of blood gas looking at the renal function, that sort of thing. So most of the, well, certainly the urgent care centre that I've seen in Alice has all of those functions, and it works very well.
And how would we best leverage the existing workforce to complement an urgent care clinic in remote and rural Australia?
We were talking about the team. It brings back to the team-based care. So the team-based care model. Okay. So you could, what we'd like to see, or what I think works really well, is if you have, I think there always need to be some medical oversight, just for what we were talking about before, that unusual case or the funny story that's not quite working, because that's where we sit in the system as we do the diagnostics and provide that safety net. But certainly, we have practitioners that put plasters on. We have will manage basic fractures, that can do the blood tests, that can take the ECG. So there's lots of other activities that the doctor doesn't necessarily need to do, and certainly there's a lot of other very well-trained practitioners that can. So in fact, you can improve the efficiency of that one person remarkably.
But you did say in your previous answer, sorry to cut in on you, I'll let you finish.
No.
Okay, but you did mention taking x-rays. So does that not happen in the urgent care clinics now? To the best of your knowledge?
It should.
Okay.
I'm just trying to go through my memory. I think there's a few that haven't had access to that, but part of the requirement is to be able to do your basic x-rays.
Sure. Now, in your first line of answers to the chair, you were talking about the freight costs, and I understand freight costs as well as anyone. There's no dramas there. And you're talking about cannulas and all that, and I'm just trying to get my head around. So the medical deliveries for cannulas and that sort of stuff, can I take it there's a vast difference in implementing one regionally than there is in the metropolitan areas? Predominantly because the freight to get the cannula there, is that what I picked up?
That's part of it. So there's a couple of things that sit here, it's just logistic-wise. So
sure.
Supply lines can be a little bit challenging as you sort of go more and more regionally. So your stock you need to hold is higher, and that imposes a cost just on its own. So for example, in the middle of Canberra, you would be able to get replacement stock very quickly.
Right.
But if you're out in a regional centre, that supply line takes longer to get, so you need to hold a higher.
Oh, you need to hold, yes, okay.
Yeah.
Because I'm thinking the freight side.
But also the freight costs more.
And would you air freight? Is it air freighted or road?
Some places require air, some places can do train, some places go by bus, but the whole thing costs more just to hold them in
I just know what the transport companies get paid, so they're not getting it all, I can tell you. So I don't know where it's going to, but I'm not challenging you on that. And my last one, and look, feel free to take this on notice, Doctor, and I just want to clarify this one. How come I can go skipping into a doctor whistling, clicking my ears, and I feel fantastic until I walk out and then I feel rat shit? What's that all about? Sorry, I shouldn't say rat shit. I'll withdraw that. All of a sudden I'm crook.
I think you feel
enough of the frivolity.
Rodent excrement, I think you feel, yes.
It must be a doctor thing. Thanks, Chair.
Thank you. Senator Colbeck.
Thank you. The structural engagement that you've talked about with Senator Cadell in relation to how coordination can be better managed. I mean, what are the things that are driving that? Is that the silos effectively that exist within the system, say between what you're doing at what I assume is the hospital run by the government in the Northern Territory versus the private practice, and the capacity of the system for information flows? Is that sort of part of how that's inhibited?
So there are definitely challenges. You've raised a couple of things there. One is the IT systems. So very few IT systems actually speak to each other, even within a state. And even between different hospitals, it's a real challenge. I would do a shout out to the My Health record. It has actually improved things. So if they're uploaded, we can see what other people have done, and certainly our records go into that as well. So that is a useful thing, a useful strategy. a very useful initiative, but still has a bit of work to do to bring it up to speed.
Yeah, I mean, the difficulty of establishing a single health identifier, a health record or whatever it gets called, gets conflated with a whole heap of other matters that people are suspicious of, I suppose, and therefore the utilisation of that becomes problematic in a holistic sense. Are there any other ways that we can improve? I mean, that's the obvious one, I know. And
yeah, the IT systems are definitely an issue. The other thing that I think that for us, that we in the emergency departments find quite challenging is the opening hours of other services. I call it solar-powered services, really, and they're mostly business hours, and not on weekends or public holidays. But the need is almost always after hours, you know, particularly around domestic violence or acute injuries. That's when we need the services available, and
that's when you need the capacity.
Correct.
Yeah.
Yeah.
Okay. You talked about your costs in that regional or remote setting. We had some evidence in Queensland a couple of weeks ago from the Western Queensland Health, PHN, but also from the Queensland Government. So what would you say the shortfall is in what comes through with the Medicare provider recompense? So I think for an MMM7, it's 190% of the MMM. Oh, they're only using two M's.
In the modified one-hash model, it only has two M's. There you go.
Anyway, isn't 190% of MM1? Is that the problem? Is it the indexation level that's the problem, or?
Indexation is part of the problem. The other problem is just the number of providers. You know, so all providers have a capacity level. So because there's fewer providers to give the service in regional Australia, and they max out, there's an underspend in that space. So there's basically what they're showing is an unmet need. So there's people there that are just not seeking care or not getting care.
Not seeking care or not accessing care.
Yeah, correct.
So, but if the costs, I'm trying to get to the point that you made about the cost being so much higher because of transport and all of those other things, which we understand. What proportion isn't being met? How much short is it in terms of what it's actually covering off?
There's been some modelling through other agencies, which I don't know off the top of my head, but I think the AMA, for example, has some numbers around this, and the National Rural Health Alliance, I know, has put out a document on this sort of these numbers. But it's substantial. We know that there's a significant, what they call an underspend in regional Australia compared to what you see in the city.
So in Queensland Health said in, say, their services that they were providing in rural or remote areas, the bulk billing rates provided by the Commonwealth were only meeting something like 75% of the cost of delivering a service. Where would that sit in terms of where you... And the Queensland Government is topping up the rest through the service that it's providing.
That sounds right to me, but we work in public funded emergency departments, so emergency physicians, so it's sort of outside of my area to sort of say what the shortfall in urgent care or general practice would be. So it sounds right, but I'm not the right person to ask that question.
Yeah, okay, all right. So in terms of those people who you're not reaching or the system isn't, I mean, what needs to change in the way that the service is being delivered to actually cover off that shortfall?
One of the big challenges is that it's really quite an artificial distinction, but the distinction between sort of what Commonwealth funds and what the states and territories fund, there's that cost shifting part that happens. Human nature is to sort of game a system. So if it's there, it gets gamed, and that does lead to problems. Access to outpatient clinics, for example, is very much encouraged to go out privately, but when there's no private providers in the system to provide that care, where do people go? So and that just adds an extra travel cost onto people as well. So it's, there are issues. I think that could be addressed, but it'd be very difficult to do. I think aged care is a particularly interesting sector to look at for that as well. One of our challenges there has been access to appropriately staffed aged care beds. What we've noticed from the emergency department, looking at why people get stuck in hospital for a longer period of time, we are seeing more people required specialised aged care beds. So it's not just aged care people sort of accumulating in hospitals, it's people with usually behaviours of concern, so agitated dementia, things that we know aren't going to get better, but they're difficult to care for. And we've seen the sector, aged care sector, which is largely private, sort of probably lose their risk appetite for looking after those people. So the number of spaces available for them to go is dropping off. And when you've got nowhere else to go, they come back to the emergency department, and then they stay in hospital beds because the discharge planning just isn't there.
Hospital bed's not necessarily the best place for a person with dementia in any circumstance.
Yeah, we agree with that.
So in terms of service delivery into those more regional areas, how a lot of the conversation we've had is been done in the context of bundling of service types together to make a broader viability. You operate and work in a very unique part of the country with a whole series of layers of things that wouldn't exist in other regional areas or remote areas. How do you think that the system can evolve to cater for those sorts of things? Is it just about the funding rates, or is it about improving the scope of practice that people can use? How do we ensure that people can get access to Medicare services in those areas where it just doesn't stack up as it is currently financially? Because that's one of the real inhibitors from what we've seen on this committee.
Financial levers are one part of the solution, but it really is about addressing that maldistribution of the workforce and getting people to live and work in our beautiful regional centres. Maldistribution isn't just a medical issue either. It's also most of the other professions struggle to get people to move out of a city. So it's not just medical. It's also getting the nurse practitioners and the specialised paramedics and get people to move into our regional centre. So that is a wicked problem that I think we've been addressing for, I've been working for 30 odd years, and it's been pretty much the same problem all that time. I don't know if we've really solved it. I think some of the initiatives around sort of rural training for our medical students and really encouraging people to do that is beginning to show output. Just because of the length of time it takes to train someone, it's, whatever you implement 10 years ago is going to take that time to get through. And I think we are beginning to see more people that are coming through the system with an aim and an intent to work in regional Australia. So I think that's a good outcome, and it's a model that could probably be sort of implemented in the other craft groups as a success.
Do you think that some of the hierarchies that exist within the medical profession inhibit this? You talked about the work that you do with some of the remote service providers and the engagement that you have them in doing the assessments and deciding whether somebody comes into the hospital or not. Do you think that that's also a cultural inhibitor? I mean, in remote areas, is quite often not a choice. I was in a great little practice last week that's nurse practitioner led with a paramedic. That the nurse practitioner runs the practice. There's some GPs that come in and provide GP services within the clinic. It operates as almost as an urgent care clinic as well, and the nurse practitioner and the paramedic basically do that stuff and eminently qualified to do it. But there's also there's still a perspective, I suppose, that comes within the system that provides a bit of an overlay that's not supportive of that as a practice. And yet, for the 1,000-odd people that it's serving in that regional community, it's doing a great job, really well supported, respected, and doing some things that most general practices aren't doing, including effectively operating as an urgent care clinic with extended hours, which is something that you've talked about. So, I mean, is that something we also should be talking about?
It is being talked a lot about at the moment. Sort of extended scope of practice is definitely on the cards and something we've been talking about for quite some time now. The hierarchy in medicine is evolved for a reason, and it's there, I think, for a good reason. At the end of the day, this is all about the patient and making sure the patient's safe.
Absolutely.
And thinking about the training. And this is what I was linking back to what I said before. What's the role of a doctor in the system? And I think it really is in the diagnostic space that helps people keep people safe and catching those unusual cases that come
Which was
through.
reflected in the conversation I was having last week.
And for us to get through that process, it's 6 years of medical school. It's another 3 years as a junior doctor, and it's another 5 years as a specialist and a lot of exams to get that before we even let you practice independently. So the amount of supervision and supervised specialist hours that people put through is just not equivalent to the other specialties. Now, that doesn't say that there's not a role for them, and it brings me back to that team-based approach that we're very comfortable with. I work with some amazing paramedics, but we have a system, and a hierarchy in that space is sort of important for maintaining the safety. Like I said, it's evolved there for a reason, and it's sort of evolved in a similar sort of way across the world, so it's a thing that sort of works. So models where you have nurse practitioner and a paramedic practitioner in the same practice, as long as there's some medical access in that space, I think that's a really good model and something we could definitely roll out. I do have some concerns of not, if you remove the medical part from the system completely, I do think that there's some safety issues there in just the basic training that people go through to keep an eye on what's happening. Doesn't mean the doctor needs to see every patient, but there needs to be someone there available to talk to, bring up a case or bounce an idea off.
So I just want and then go for your life. So I don't disagree with anything that you've said there in terms of that appropriate hierarchy. My question, or my problem, I suppose, is the way that the system actually works, where we're having this bigger conversation about scope of practice across the health system. There are a number of elements of the health profession, nurse practitioners, paramedics, pharmacists, who aren't operating at their full scope of practice, but we have this continued resistance to change, which in my view, and take that as you like, but my view is that that's inhibiting us from getting the maximum capacity out of the health system, because we have this resistance to change and almost demarcation, protection of turf. Now, I understand the motive. I think you've very nicely articulated that. But actually achieving that full scope of practice, which given we're tight on people, getting more out of the people appropriately that we've got would make a huge difference to our capacity to deliver for the people that we're looking to serve.
It sounds logical, The problem here is what I was talking about before, is that the maldistribution doesn't just apply to medicine. You know, Tri-Pharm, there's a limited number of pharmacists regionally as well. There's a limited number of paramedics. It's very difficult to get any of the craft groups to work in regional Australia. So,
in some locations I agree, but my beef is the way that the resistance to change, I suppose, which is not an unusual thing.
Just something you said, when we're talking especially ED and emergency things, if we're talking about integration of different practitioners and whole scope, how does it go on legal liability on insurances and stuff like that? They may not all work for the same employer. How does someone at the front, if it's an underage, assess legal competency when a doctor could compared to potentially a first responder? Or even with Alzheimer's at the older age, these things, how does that integrate into what you can and can't do in rural areas?
it's one of the reasons, particularly in regional Australia, why we get the medical staff involved, because once you start talking about a patient, you basically assume responsibility for it, so you become ultimately responsible for it. I do think that there's going to be some interesting challenges as we go forward as to how you cover liability for independent practitioners of other groups. So how are you going to manage the pharmacists, for example? I don't really have any suggestions in that space, but it'd be interesting to watch.
About introducing these people, I'm thinking, well, everyone's got their own policy, everyone's employed by different people, and we all know insurance companies love to dodge a claim. Okay, anyone else? Thank you very much for your evidence today. Thank you, Doctor.
Thank you. Thanks for your time.
Next up, we will pause for a brief second while we bring up the next delegates, Mr. Paul Dale, Mr. Andrew Wiltshire, Mr. Falco Teal, and Ms. Helen Souris. I now welcome representatives from the Medical Technology Association of Australia. I understand that information on parliamentary privilege and protection of witnesses giving evidence to Senate committees has been provided to you, correctly? Yes. For the Hansard record, we'll start at this end and go along. Will you please state your name today, the capacity in which you appear?
Sure. Thanks, Chair and Senators. Thank you for giving us...
Just your name and capacity at this stage.
Okay.
Sorry.
Falco Teal. Biotronic Australia is the company I work for, and I'm the Director of Clinical and Regulatory Affairs.
Andrew Wiltshire, I'm Head of Digital Health at the Medical Technology Association of Australia.
Paul Dale, Director of Policy at the Medical Technology Association of Australia.
Helen Souris, CEO and Exec Director of CardiHab and Board Member with the MTAA.
Right, you can work out, if anyone has opening statements, you can work out your own, or I'll let you go.
Thank you. Well, Chair and Senators, thanks for the opportunity to appear today. The Medical Technology Association of Australia, or MTAA, represents companies that develop and supply medical technologies used across Australia's healthcare system, including TGA-registered digital therapeutics and remote patient monitoring technologies. Our evidence today is focused on a practical Medicare funding gap. Medicare is very good at funding appointments, but for many rural, regional and remote Australians, the challenge is not only getting an appointment, it's staying connected to care after the appointment has occurred. That matters because rural access barriers are not only clinical, but practical and economic. Travel times are long, and time away from farms, businesses and communities can be particularly impactful. Modern care increasingly happens between appointments. A cardiac patient may need rehabilitation support at home. A cancer patient may need symptom monitoring after returning from treatment. A person with chronic disease may need review, escalation or coaching between GP appointments. Evidence-based digital therapeutics and remote patient monitoring can help address these gaps when they are clinically governed and integrated into usual care. They don't replace necessary face-to-face care, They help clinicians, nurses, allied health professionals and visiting specialists extend their reach, identify deterioration earlier and support patients closer to home. The funding architecture has not kept pace. Medicare generally funds the appointment, but it often does not adequately fund the clinical work required between appointments, onboarding patients, reviewing remotely generated information, responding to alerts, supporting adherence or coordinating mixed team care. MTA therefore asks the committee to consider 3 linked reforms. First, targeted Medicare funding should recognise clinically appropriate remote monitoring, data review and patient support between consultations where these activities are prescribed, recommended or overseen by an appropriate clinician. Second, funding should support evidence-based digital therapeutics and remote patient monitoring as part of mixed team rural care. And then third, government should prioritise rural, regional and remote communities for these funding pathways where the need is greatest. If funding models can work for small providers in thin markets with workforce shortages, they can provide a model for broader Medicare modernisation. So, Chair, this is not a technology argument, it's an access argument. The technologies and care models exist today. The missing piece is a Medicare funding framework that supports clinician-led care between appointments, particularly in communities where the need is greatest. So Helen Souris from CardiHab and Falco Tiller from Biotronic join us today because the examples highlighted in MTA's submission demonstrate how clinicians supported cardiac rehabilitation and clinician-led remote monitoring are already improving access to care, while also illustrating the funding gaps that continue to limit broader access for rural and regional patients. I'll just invite Helen and then Falco to briefly overview the technologies and the services they provide.
Thank you. We are providing a digital therapeutic, which is essentially apps and programs for people to receive supervised care. We are a product from CSIRO days to help deliberately care for those 80% of people who currently get nothing after they leave hospital, and a heart attack is a common cause. Our program particularly relates to the terms around items C and D, where we've been able to demonstrate 71% reduction in hospital bed days because of access to our programs, particularly for those in regional, rural and remote communities, but also in terms of our design of our product, which is for mixed nurse-led teams and allied healthcare professionals to lighten the burden on GPs and cardiologists. Their services are only required by exception. Most of the care can comfortably be delivered by nurses and allied health.
Thank you, Falco.
So Biotronic makes implantable cardiac electronic devices, including pacemakers, that have the capability for home monitoring, which means the patient can be monitored by their cardiologist daily while they are at home. Previously, these patients had to see their specialist, their cardiologist, every 3 to 6 months to check on the status of their chronic cardiac disease and also the status of the device, battery, etc. Whereas now they only need to see the specialist if an issue is identified via home monitoring. Yeah.
Good technology.
So back to you, Chair. That's our opening statements. Thank you.
It's good to be the king because I might go first. So on that technology, not being exposed to it, you hear that and you think now it's logical when you say this. What the cardiologist, did there be alerts sent, or does your device send alert, or do they have to review the history themselves? Are we looking at a chart, an echo chart? What are we looking at? What is the thing that causes a cardiologist to be able to review a patient?
Yeah.
I get what you're saying about the funding. He's not going to look at it because he's not getting paid for an appointment. I can see that history. What is the process that might raise an alert to look at a patient?
Yeah, it's actually both. So the data is transmitted every day and it's kept in the system. And if there is something out of range, out of the ordinary, the doctor can also select to be alerted either via email or a text message. And then they log in and then they can basically look back at the history of that, that impedance change in a certain way, which then gives them clues as to what might be going on.
And there's currently no funding available for the doctor for their time.
Well, actually, there is funding. So Biotronic actually helped to establish that in 2015. So there is a Medicare item code for doctors reviewing these patients. However, doctors tell us it's too low for the amount of work that is involved in monitoring these patients. Yeah.
If I can just add, Chair, that that is probably the only, there's possibly one other MBS item number for remote monitoring. This is really the only major area where remote monitoring is remunerated through the MBS. So it's a success story in that sense.
And if I could add to that, that took 3 MSAC submissions and 8 to 10 years to get
Two MSAC submissions, 8 years, and all this grey hair here. Yeah.
And you give other. You want to go on this? Yeah. You get other examples in here. So what would be examples of some of the ones that aren't remunerated where that could be?
Well, an example that we have that we did provide was essentially is the Elector example. So obviously radiotherapy interventions, that's a whole issue in itself, but those patients that are actually experiencing going through treatment, there isn't any direct funding for the technology that would actually allow them to be monitored for toxicity issues, monitored for change in their condition or their state proactively. And that's really what the technology potentially can do, and to build a connection between the patient at home and actually the treating clinician. And really at the moment there's no, whilst the intervention is funded and the face-to-face care is funded, or even through telehealth consultation, that additional monitoring component is not supported.
Okay. Mr. You mentioned the studies about 71% reduction in bed days. That's a monstrous result. What was the longevity of the studies? What are we talking? Patient health? Can you just expand upon that?
Absolutely. So it was an independent evaluation by the Baker. They showed that we were able to reduce bed days by 71% for people who had access to our program compared to usual care. In addition to that study, they also looked at survival rates, and we do improve survival. We can add an additional 1.434 quality adjusted life years to a human, which is a really big deal, especially for people who are suffering and recovering from cardiac event. They also demonstrated that if our model was deployed, it's 87% of the time more cost effective than usual care. And so there are health economics evidence, there is life-saving evidence, there is hospital bed day reduction evidence. Our completion rates for our program are 91. This is set against a backdrop of solutions where dropout rates for attending face-to-face cardiac rehab are very high. Around 50% of people drop out after week 2. And our program gets them all the way through. So there are fantastic benefits, independent data, TGA registration, and the biggest limitation for us is there is no funding mechanism to enable the services to be provided in community-based settings. There is no codes available for nurses and allied healthcare professionals who do the lion's share of the work to deliver the programs. Okay.
So if you're talking about dropouts, failure to attend, I believe, are they known cancellations or just don't shows, or...?
People might start, about 30% of people who do get offered rehab start a program, but they go for 1 or 2 weeks and realise that they don't feel comfortable, or the travel burden is too high, or
I'm fine, it'll be good, I don't need to go anymore. Yeah,
correct.
Yeah.
And that is the biggest risk. You can imagine a group of us now having a heart attack and rocking up to a group and not feeling connected or feeling supported, or having to travel. Even 40 minutes of travel for someone can be quite a burden, especially after a major cardiac surgery. So they just don't show up, and They go home and they get nothing.
So the other consequence, they're not being treated right, and we have unused capacity in treatment programs because we've got FTAs, yeah.
Absolutely, and the burden on GPs, particularly in regional rural communities, is high. This burden can be shifted very comfortably to qualified nurses and allied health who can deliver a great model of care through a standardised digital therapeutic which gives guidance and training as you're doing the program on how to do good quality remote care.
I shouldn't comment behind, but you're getting nods from the doctor that was just previously.
They don't want to do rehab.
Yeah, that's right.
They want to do the diagnostic work.
So, it was interesting reading submission, reading things. I think the funding things are right. How are we going in medical technology? I mean, communications are better. We see it used in telehealth, as now video health. But these devices, smart devices. So, how far can we go? What are the most cutting edge things that we're using in the fields now?
I think some great examples. A company that's not actually a member of ours, but saw some of the things recently at a conference, They're providing a device which gives real-time telecommunication in Indigenous communities and remote Indigenous communities. They can have a clinician on the other side, but it also has blood pressure monitoring, oxygen sensing, glucose monitoring, all in one platform. So you don't actually need a clinician there at all.
Present, yeah.
Dialysis, so supporting people who are getting peritoneal dialysis at home in remote communities, but also monitoring the progress of that without having to travel into a clinic. I mean, there's endless examples of things that our members and the broader digital health community are delivering in this space. The cancer care, point-of-care diagnostics, which previous witness mentioned is critical in this area, is being able to do diagnostics in small clinics without having specialised pathology services there. Yeah.
I mean, I think it's what's key. I mean, wearables, and we're talking, when we're talking about these kinds of things, we're always talking about therapeutic goods administration approved products. Yep. There's a lot of things out there for wellness, and they'll tell you what your heart rate's doing and those kinds of things. But we're not. Theranos
is good. One bit blood pressure.
Yeah, that's right. There's a lot of those things, but what we're talking about is TGA approved devices that actually have a medical use, and that very importantly can. I think they can do a couple of key things, and that is send important information back through to a clinician who can review that information and make good judgments, including whether that person needs to be brought in. And then secondly, also to guide the patient in managing their own care more effectively. And yeah, I mean, we know that we can design high quality interventions. We've seen a lot of it in mental health, but we can design high quality interventions that patients can use at home under the support of their clinician, not by themselves, without any kind of support. So I think, I mean, that is becoming more exciting, and I think we don't really have a modern healthcare system unless we're taking advantage of those things.
One of your recommendations, I think, was invest in workforce and technology competency or capability. Mm-hmm. Most people I've dealt with in the health industry are intelligent, very smart. But is that difference between people in the care factor and the technology factor? Is that a problem, that transition between, people who have a better caring side of their loan, not people who put them in or anything like that? That's what you want. You want them trained in technology a bit better. Is that what we're talking about there?
Yeah, so I mean, I think it's broader than that. So yes, a little bit of that. Although again, if the systems are well designed, you don't need a lot of technical capability to be part of the care delivery. But it's also working within that team environment, learning how to use the apps and the technology within the team environment and connecting it to the broader healthcare system and how that works. And that's one of the challenges that we've got at the moment, because the existing chronic condition management arrangements, they're important foundations that exist in our current Medicare system already, but they were designed around kind of care plans, referrals and appointments. So the digital therapeutics and remote monitoring rely on clinical-led activities between those appointments. So it's how you bring those teams together and how you get them to work together, but that's often not funded in that way. So Helen, this is a great example for you.
If I could add, we have so many regional nurses and doctors and cardiologists and ED physicians who want to use our programs, but they can't because they're not funded to do so. So I've sat with nurses who are enthusiastic and wanting to actually do their cardiac rehab, but they don't have an item number. And business case after business case, they get knocked back. I've sat with ED physicians who said, if I see someone in my emergency department, I'll use my own personal phone and scan a QR code so I can get this patient into the program because I know the benefits, but I can't actually do that. I'm using my own phone, my own details, my own information to get that person into care. These are really big and important differences we can make to people, and we cannot do that because they're restricted by the access and funding issues. And I feel a little bit passionate about this because we've had a patient come to Parliament House last month. He was from Townsville. He lives 200 kilometres away from the nearest centre and had coronary artery bypass surgery, the big Superman stuff where they rip you open. If it wasn't for our program, he wouldn't have had access to any rehab. Right. And that's a really big procedure. By having access to our program, he could do his rehab from home. His family kicked in and helped around the farm until he got strong enough to do his rehab from the field. And then he continued to do his rehab from the back of his ute, supervised via telehealth with our app. These are really profound impacts we can have on people. Nurses and doctors want to use it, and I'm frustrated at 10 years on in our journey, we still can't get access to these services despite the passion of the clinicians who want to learn how to use them. If we fund them, they learn how to use technology. They learn how to use proper technology, not apps that are off the App Store. Medical device grade wearables. This is what we need to train physicians on how to use our products. We need to give them access to the funding so their time is covered.
And the funding isn't consistent or connected. So we've seen lots of pilots and lots of very successful pilots in all sorts of areas, around diabetes, around cardiac, around all kinds of things. But when the pilot ends, even if it's successful, there's no mechanism to take that pilot into an ongoing funded program, because we don't have the submission pathways and we don't have the established pathways for ongoing funding for these things.
So no program exists where a successful pilot can transition into rollout?
I've not seen.
Yeah, I think there are different ways funding can occur, as I'm sure the committee has heard often enough. We have MBS item numbers, for example. We do have funding through for some things through PHNs and other forms of block funding. I think that when we talk about the MBS, we've highlighted already that there is not sufficient funding for the management of this kind of digital technology. I think on the other side, in terms of block funding, and we would certainly support the use of block funding or mixed models of funding, particularly for rural and regional and remote, because of volumes, which I'm sure you've heard a lot about, is that sometimes those funding programs are not they're not specifically addressing the digital component, and this has been called out before, that the program needs to actually allow funding for the digital part of it and for the digital component, and I think that that's not what we're seeing. So what we experience is that if the digital funding is not specifically called out, you default back to your old model of care. You essentially prefer what's already existing.
And the allied health components that go with
So
it.
if I'm freestyling and just not testing my own theory, just saying it first, and then I'll probably regret it when I hear the Hansard transcript. For drugs and treatments, we have PBS. We have a process going through. There could almost be one for digital treatment and these rehabilitation processes where they go through that same, can you show bed days, can you show these things, and they're assessed, the programs and the systems could almost be approved in a similar manner, couldn't they?
Yeah, we would support that. I think
that's literally just made up on the spot, so don't take it as
Yeah.
That sounds good, possible.
Yeah.
That's right.
Done deal, yeah. Okay.
It brings a perfect parallel to some of these technologies. They're all clinically supervised, but they can be prescribed in hospitals, they can be prescribed in community-based settings, in general practice, and in the same way that medicines can be subsidised and accessed, it should be the same for digital therapeutics in the sense, the way that our programs are used.
And Medicare, through MSAC, it's a very service-based, clinical service-based mechanism. So it's looking at a specific patient, a specific indication, and then looking at the outcomes of that. But it's generally for the clinical service only, and so that's our only really submission pathway for this. Unless there's a sort of small programs cobbled together, that program isn't really designed to look at this. It's not looking at the full picture of the software, the hardware, the allied care support that goes with it, and the whole continuous program. So even if you do, and again, the pacemaker monitoring one went through that MSAC process, but it's a great example. They really struggled to review it. And it is quite a simple version of this, but they really struggled to review it. That's why it took 3 submissions to get through. The process is not designed to look at this. Yeah. We need a differently structured program to assess digital health solutions.
So maybe to expand on this, what MSAC struggled with, the Medical Services Advisory Committee struggled with, was traditionally they fund a consultation that is face-to-face, patient-doctor, and concurrent, of course. Then there is telemedicine, where it's not face-to-face, it's remote, but it's still concurrent. And with these remote monitoring services, we were asking for something that is not face-to-face and not concurrent. Yep. The transmission takes place somewhere at night, and the doctor reviews it whenever they have time. And that was just very hard.
Yeah.
Unless there's an
An alert, yeah.
Yeah. And that was just very hard for them. So that's where we feel something needs to change to allow the more flexibility to adjust for these new models that come along to be able to be funded.
Okay. And I've taken too much time, but it's good to be the king. Just last question. You mentioned CSIRO. Were you a commercialisation project or did you buy the tech off?
No, we spun out of the CSIRO 10 years ago.
Okay.
It was an initial PhD student project.
Wow.
And then we became Cardiac Proprietary Limited. And since then we've commercialised our product as a digital therapeutic.
Oh, nice. Okay.
Yeah, a couple of quick ones. Thanks, Chair. Mr. Thiel, your product, magnificent. Okay, congratulations on what you've done on that. And the figures that you come up with, Ms. Sue, is very, very impressive and it'd be great to see that continue to climb. And please don't take this personal, but every second sentence you have, you've got funding, funding, funding. So my head becomes cabbaged after 21 years in this joint because I hear about funding. How much funding are you talking about? I'm not knocking you. I want to know because, you see, we can go back and go beat up a minister or a minister's office and say fund, but we've got no idea how much you're talking about.
Yeah, it's a really valid question.
I'm not going to go beat up the minister.
We've been asked about.
They're listening anyway, but...
Yes.
Can I add a supplementary to Senator Still's?
As long as you don't make my head any more blocked than what it is.
No, I won't. I promise. I'll try not to. Where does it get funded from now? Those things that those rehab services, how are they being funded now, or are they not being funded?
And how much?
Currently,
and how much?
85% of our of private health insurers fund our program and deliver the programs to members. And we have one public health service, the Tasmanian Health Service, statewide funds the program to enable access across Tasmania. That program has been in place for 5 years. Everywhere else that we have piloted, we've not been able to have sustained funding. There are NEP item codes that exist in the public health service that cover the services. Our program has been proven to be equivalent to face-to-face care in terms of quality outcomes, but there is no funding mechanism for software. And so therefore, most of the health services that look at our program don't continue to use it.
How much is your software?
Our program has a licence fee and a per participant fee. We charge $275 per program, and most of the patients that receive our program are those that have had a cardiac event or procedure. It's a very small cost relative to the scheme of a readmission or a hospital procedure.
Okay, so come back to mine.
Yeah. Firstly, I think it's important to realise, I mean, one of the things we notice, if we're just talking about apps, for example, I think there's something like 300,000 health apps on the App Store right now. The number of those that are TGA registered and improved is far, far, far fewer. So we are not talking about an enormous influx, which sometimes government understandably fears. We're talking about a very defined number of applications and other forms of technology. At the moment, those technologies are available, as Andrew has said, but we would not be talking, I wouldn't even say hundreds of millions of dollars. I would say that we're talking, millions, maybe. We have estimated that a program like this in the first 4 years would be in the order of 30 million, based on what we've seen overseas. Over that 4-year period.
This is just for the apps?
This is just for the apps and the technologies, that's right. So, I'm sorry.
Not the monitoring associated with it?
Well, the monitoring associated with it, that might be additional to that. We would hope, as it is in the case of CardiHab, that is often substitutionary.
Yeah, okay.
That there are costs already in the system that would be replacing.
And that's why it's difficult to give a very simple answer to that. You can sort of cost the technology components of it, but it's also, oftentimes you're replacing an existing service, potentially even more at better cost efficiency than the existing service. You're also hopefully avoiding future hospital admissions or worsening of chronic disease conditions. So, it's a good question. We should probably try to get better answers to you for that, but it's actually quite a difficult question to answer.
And it's not having a crack at you said, no. Because it gets all very confusing because you have a lot of people who've got nothing better to do than listen to Senator inquiries, and there's a lot of things that will be coming, health should be funded non-stop. We get all that argument, that's great. And rural people should get access to health as as much as city, but you've got all that sort of stuff. But then there's the other side of the argument. We see private enterprise sitting there saying, well, the doctors aren't getting paid enough and we want more money too. That's just me putting my trucky bent on everything. So it would help us if you come up with more specific lines around what is the fix or what possibly could be the fix.
But, you know, a good example, my mother-in-law lives in Barcaldine. The state government flies her to Brisbane twice a year to get follow-up with a vascular surgeon. A telehealth consultation with a handheld ultrasound could be done in Barcaldine and save the cost of the flights and accommodation and the time. And, you know, so it's a relatively small cost in that specific instance compared to the existing.
And just to clarify, I mean, I spent a lot of time, I represent the Kimberley in WA, and that's where I made my living all those years ago. And I know the challenges for those poor devils up there trying to get allied health and all that sort of stuff. So I get all that, you know. But I just wanted to share my thoughts with you.
And the point I want to make, all these technologies undergo what is called a health technology assessment. So it's not that we're asking for free money. These technologies have to prove their value, their economic and their clinical benefit. Sure. One thing we encountered when we did the remote monitoring MSAC submission was that MSAC takes the scope very narrowly. They look at savings to the government, even the federal government, I believe. They don't take into account things like patient travel, time away from work, a carer that has to go with them on these trips. So that there's potentially much higher benefit, but MSAC doesn't consider that when they set the reimbursement for their fees. And then, of course, what doctors do, if the reimbursement is not enough that they receive from Medicare, they charge the patient out of pocket. Yeah, so that's where the shortcomings are.
Yeah, thank you. Thanks, Chair.
I have one that's sort of a little bit left field, which is actually connectivity. And, you know, we're reading, and this committee actually did an inquiry a couple of years ago into the shutdown of 3G, those sorts of things. And a submission came to this inquiry this week from an organisation called Motherland, which is really interesting because it's actually what the patients are saying. It's not what the clinicians or anyone in the system are saying, it's what the patients are saying. And in this context, something that caught my eye, 13% of rural mothers surveyed do not have adequate internet access for telehealth services, so impacting on this. 32% named affordability as a problem and 17% just want reliability. So a real issue in that sense. And also, in terms of one of the recommendations they made, they're talking about, in a rural and regional sense, getting to see the same person twice in a row is an issue, and how we manage that through the system, although some of the things that you're talking about may potentially impact on that, depending on the service type. With the monitoring that you're talking about.
We've built our solution to enable people to use it even if they don't have Wi-Fi or internet access intermittently, so they can still get the educational articles, the prompts and reminders for their medications, to do their rehab from home, and then when they go to town, the data synchronises with the health service that's looking after them. So we do accommodate for some of that challenge, but not obviously the complete issue of lack of internet access in their home. When it comes to the ability to connect local people, our goal will be to engage regional and rural health services to be the virtual care providers, not just send the call back to the centre or the metro city. So if we can engage community-based care to deliver the programs to those people in their homes, then that builds that connectivity to the people and have some continuity of care for the person as opposed to a stranger each time.
Look, I'd say it's not an issue. It clearly is. I've just spent 2 weeks in Flinders Ranges. There's definitely a lack of connectivity, but also I think it's rapidly improving. So I think every second or third car I saw out there had a Starlink receiver on the roof. I think NBN Co has just done a deal with Amazon Leo to provide replacement for the Sky Muster service. So I think, you know, it's rapidly improving, but it's not a problem. But I think it's still workable in many communities.
All right, I might leave it there, given time.
Thank you. I don't think any questions were taken on notice. Thank you for evidence. And your excuse. Thank you.
Thank you. Thank you.
We will now welcome Dr. Hamish Meldrum, representing Ochre Health.
It's like a scene from a Chevy Chase movie, this inquiry. It's
Yeah.
like, doctor.
That was interesting and informative. I learnt there was an item number for reviewing a something, a digital bit of digital information. I didn't, as a GP, I didn't know there was an item number
Really?
for that. No, not at all, not at all. And I think most GPs would be unaware of that.
I'm talking out of school, but my wife is amazed how many new grads come out knowing all the billing codes better than they do.
Wow. They did teach that. They didn't used to teach that.
Yeah, that's right. I now welcome Dr. Hamish Meldrum, representing Ochre Health. I understand that information on parliamentary privilege and protection of witnesses giving evidence to Hansard Senate committees has been given to you. Is that correct?
Yep.
Yeah, okay. For the Hansard record, will you please state your full name and the capacity in which you appear today?
I'm Hamish Meldrum. I'm a rural journalist and I'm the CMO of Ochre Health.
Thank you very much. Do you have an opening statement or opening comments?
Yeah, look, I'll explain a little bit about who I am. I was a GP I'm originally from New Zealand, you can probably tell that. I came to Australia and worked in Sydney. I really enjoyed doing rural locums. They were really, it really was fantastic work. I got to do, because I'm quite passionate about emergency medicine, I worked in urgent care in New Zealand and I worked in ED in New Zealand. And when I got to Australia, I really found doing rural generalism, I suppose what it's called now, like working in the hospital in ED and being a GP was fantastic work, very professionally rewarding, awesome work, liked it so much. I went out to Dubbo, I trained in obstetrics, learned how to do caesarean sections, and moved to Burke for 5 years and provided on-call emergency services, GP services, obstetrics, including caesarean section services in Burke. I'm not sure how many of you are familiar with Burke, but it's a town of 3,000 people back then, and northwest New South Wales. So, I just want to say how wonderful rural medicine is. Like, it's a really great thing, and I suspect you hear stories of how not great things are, but I just want to, shout out for the regional communities and rural communities. There is a big chasm, remember, and I'm probably gone to that other side of the chasm. There's that chasm, and I don't know what politicians think. They might think the chasm happens when you get to, some of our community think the chasm happens when you get past, say, I'm going to be Sydney-centric here, and get past Balmain, you've gone west. Some people think when you get past Penrith, you've gone west, right? But really, in general practice, if I was a GP in Sydney, I would be functioning in a lot of ways similar to, my work day would be similar to a GP in Dubbo, right? Or a GP in Tamworth. But the real chasm happens when you actually cross that bridge and you're the GP in usually a MMM5 to 7 location, and you're actually also looking after the hospital and providing emergency department services as well, right? You're sort of usually juggling 2 jobs, although there maybe is a preference now to split those out, but often you're juggling 2 jobs. So that's been my experience. Ochre, a little bit about Ochre, is that we have about 600 doctors contracted to us. We also have about 18 contracts for small rural hospitals. We basically supply all the medical staffing for small rural hospitals in most of Tasmania, like Flinders Island, King Island, Queenstown, St Helens, Scottsdale. We have contracts in those locations if you're from Tasmania. We also do the northwest of New South Wales still, like Burke, Lightning Ridge, Walgett, Coonamble, those towns up in the northwest. We're probably the largest provider of GP services in ACT, where we are right now. We have large medical centres in ACT and a large cohort of of excellent doctors in ACT. So you might be familiar, you might have family, if you're based in Canberra, you might have staff that use our services. We also run 4 government-funded urgent care clinics. We also run a private urgent care clinic in Launceston. We have 2 urgent care clinics in Hobart and 2 in the Sunshine Coast. So that gives you a little bit of flavour of what we do. We're the only private company that does MMM 1, 2, 3, 4, 5, 6, 7. There's nobody else who does that. And we have a sort of a locum recruitment service that puts doctors everywhere in Australia, WA, Northern Territory, actually even in New Zealand. So we actually place locum doctors in New Zealand as well. So we've got a fairly wide breadth of activity, I suppose.
From my memory, you've got like 15 in MM1s, then there's like single figures until you get to 4 or 5s again, then there's like a 14 and a 15.
That's correct. That's always changing though. We are expanding, and that's changing a bit. Yeah, but that's correct. I suppose I'd probably make some comments about our healthcare system, because I think it's quite good to maybe go up and then go down into the detail, right? So we go up, we have a healthcare system. When I came to Australia as a GP in the 90s, last century, when I came to Australia.
Last millennium.
I remember it well.
Yeah, same. Half of the doctors in Australia worked in general practice and half worked in the hospital system, roughly, right? That was the mix, right? Now we move ahead. We're now 2026. Only a third of doctors are working in general practice, and we've doubled our, relative to population. GPs are only keeping up with the population growth in Australia. We've actually doubled the number of hospital doctors for our population. So I assume you guys are aware of that, but I think these are just basic facts that we need to understand. Our population is ageing. And it's care is getting more complicated. We knew that. We talked about in the 1990s how it was going to be, how all the baby boomers were going to retire now, and how that was going to create some burdens on the healthcare system. So we've known about that. We're more risk adverse than we were back then. There's more compliance costs. There's less patient-facing time. We ask our doctors and clinician nurses, doctors, whoever, to do more paperwork to deliver care. So there's less patient-facing time. We've had COVID, right? There's a more emphasis, and this trend was happening regardless, right? There's a trend to more work-life balance. We used to have doctors that all want to work 5 days a week, right? You can find me a GP that works 5 days a week. I'll do a little happy dance for you, right? Because most GPs really want to work, 3 or 4 days a week now. They want to work part-time. They want to do portfolio-type jobs, right? Rural economies, there's no change in the rural economies. Rural economies are, a lot of the Western rural economies are shrinking. The town is getting smaller, they're losing services. And remember, doctors are just people, and nurses are just people, and physios are just people, and pharmacists are just people. They're just people working in communities. And these communities are shrinking. There's not a lot of optimism about the future of these communities. They're affected by that, right? And it's hard to retain people when it's about regional development. So some of this conversation about rural health, we'd like to just carve that out and say, let's just talk about rural health. But actually, it's really about regional communities and thriving regional communities. Thriving regional communities, guess what? They attract people. Look at Emerald. Emerald has thrived. It's grown, population's 3 times what it was 20 years ago, and they've attracted a lot of additional doctors to town. Mudgee in New South Wales, it's got a wine industry, and people go to it, right? When the economies thrive, people move there, right? We've also got to be worried. I mean, it's a terrible way to put it, but there's that concept of urban narcissism. I don't know if you've heard of urban narcissism, but or the concept of that you look at rural in a deficit mindset. It's probably a better way to put it, a deficit mindset. So you only see rural as all the things they don't have that the city has. And you measure it by what's available in the city, and you only see things that the rural doesn't have. Right? Rural actually is just different, right? Some things are better than rural than in the city, right? If I was to get sick in Canamble and presented to the ED, I'll get seen by a very experienced rural generalist. Or if I went to Flinders Island and I went to ED, I'd seen by a very experienced rural generalist. If I went to Sydney to St Vincent's or POW with the same problem, I'd get seen by a medical officer. You know, no, all respect to that junior doctor, they're probably 1 year out, right? And they would assess me, right? So, you know, we don't think about some things are actually better. We know our times to see category 4s and 5s are better in our rural hospitals than they are in our city hospitals, right? So we've got to sort of break out of that mindset that rural is just a worse version of urban. It's not, it's different, right? So we have to think of different solutions. Yep. So probably get into some of the specifics that are raised in our submission from OCA. Look, one thing that I probably want to highlight is an independent pricing authority for Medicare. The hospitals have it. I mean, the projections for hospital spending and the projections for Medicare, if you check with Treasury, hospital spending will be predicting in the next 10 years, hospital spending will be increasing faster. These economic forces that are in the system that are producing these outcomes of a relatively shrinking GP workforce and expanding hospital workforce, they're in our system and they're projected to keep on going. There's no projection that says these are going to turn around or go backwards. I mean, these projections are baked into our forward forecasts, right? So, I mean, general practice and primary care needs its own independent pricing authority. The hospitals have it. We don't get the indexation that the hospitals get. Maybe and that's a decision, right? You know, Denmark made a decision. They closed 60 hospitals. You know, they did things like they substituted out one type of care and substituted in another type of care, right? They had cost savings and they didn't actually just take all the money back, they spent it differently, right? So they went from 95 hospitals down to 38 hospitals or whatever they did, right? So that's what Denmark did. So that's big, bold reform. We know that's beyond the scope of this committee, but you can make big, bold reforms. You've got to put something in and potentially take something away. And that was a little bit of the conversation you're having with the last speaker, right? So you can take back some funding to give some funding. It's more efficient. Maybe it works better too, right? And the trust, GPs don't have, huge amount of trust that the government will keep on indexing their fees. We have inflation of 4.2% or whatever it is, and the indexation was 2.4%. Obviously, over time, that just compounds, especially the hospital funding. If it keeps on going up every year at 6%, you can see where we're going with that, right? So the rural generalist rebates, that's something that ACRIM will come and talk to you about, and RDA will come and talk about, but that's something of interest to us as well. Rural generalist rebates, we're not on that committee. We're not really in the tent on this one, but I know Peter, I know Marita from ACRIM and RDA, obviously, and we would support that idea of rural generalist rebates. You've got to be careful, though, that we don't alienate the doctors. That how can doctors access those rebates? It might, there might be a doctor with the rural generalist qualification who can access the rebates. There might be a doctor with the same skills and the same work but doesn't have the ticket, so to speak, who may not be able to access those rebates. We've just got to be careful we're doing the right thing in terms of how we roll out those rebates when they come. They'll be years away, right? It'll go through that slow process that you're familiar with. The third thing I'd like to mention is the 19.2 exemptions. Okay, we've got UCC clinics. There's 157 UCC clinics. They all have 19.2 exemptions. So the government can give out 19.2 exemptions. State governments find them a little bit more tricky to get. They apply for them. They need the support of the GP to actually get them. They need the support of the PHN to get their 19.2 exemptions. And when they get them, they really get to control the money. They take the GP's provider number. They bill as they wish. The GP doesn't usually get told what they bill for. I don't think that's good governance in terms of using a GP's provider number. And the GP is specifically excluded from receiving any benefit. Now, I get how that might have happened. That might have happened up in Queensland, right? That might have happened in Queensland, where Queensland model is they directly employ all the GPs, right? Queensland is a little bit of an outlier. or nothing wrong with being an outlier, but it's a bit of an outlier in terms of how their medical system works compared to the rest of the country, right? So that might have made sense in Queensland, that the state, the Queensland Health, keep the money because they're directly employing the doctors, right? In New South Wales and other states, Tasmania, New South Wales, South Australia, you name it, Victoria, Western Australia, that's not really the case, right? So I mean, locking GPs out of receiving any benefit for the 19(2) exemption doesn't seem to make sense. I mean, in general practice, and we put this in our submission, we have to run a GP practice often on 35% of billings or 30% of billings, plus the PIP payments, which is probably another, 4 or 5% of revenue, okay? So, and under the 19(2) exemption, the state government can take 30% as an admin fee. They don't have to pay rent, they don't have to employ the nurses, they don't have to employ admin staff for that 30%. That's how we run our business. So 30% just an admin fee. And the other 70% can be spent really pretty much how the local committee chooses. The GPs can have some input, but at the end of the day, the power rests with the state government on how that money is spent.
Sorry, just on that one, don't the GPs share in that exemption resource?
No, I don't think they exclude. That's specifically, if you look at the guidelines for 19(2) exemptions for small hospitals, they're specifically excluded, called out as excluded. Doesn't mean there's probably ways to funnel some. You probably could buy some equipment for them in their general practice and things like that. You could, say you could probably use that to buy an ultrasound machine, which they could use for generating some income potentially, or just use for patient care. But I think to make direct payments to GPs, no, that's the one use that which it seems ironic, seeing that's their provider number that's generating the income. So I suppose that's sort of indicative of the problem we have with general practice not really being, I'll give you an anecdote to give you a sort of an example of general practice is the poor partner in the relationship and often has to take the bad deal, right? I mean, we have spending on Epic and Cerner, mainly Epic, I think, in states. That's going to be the electronic medical record. That spending is budgeted about as $10 billion. Sorry, spending $10 billion to digitise the medical records of the state hospital system, right? General practice, we use a software system where the revenue is, it's tens of millions of dollars, right? Tens of millions of dollars. We run off that system. A grant of $5 million to integrate our GP software into the Epic software would be, small amounts of money would make enormous differences in terms of our ability to speak to the hospital system. If you go and talk, I haven't spoken to them recently, but you go and talk to the vendors of the GP software, have the guys from the state government come and spoken to you about spending a little bit of money, and we're talking small money, very small rounding error type money when you're talking a $10 billion of budget across the different states. How much? Have they come to you to integrate our software into your software? Answer's no, right? They talk about how they work with general practice, but we're often forgotten about, right? We're often not really thought, and the politicians call us sometimes the backbone of the healthcare system. Things like those terms seem to roll off the tongue, but we know that general practice gets about 5% of the health budget. The public think we get about 20 or 30% of the health budget, but actually we get about 5 or 6% of the whole health spend in Australia, and it's been shrinking. It used to be 7%, now it's down to 5 or 6%, right? Michael Wright, he's the RACG president. He's also an economist. He's done all that work and published that work. Michael would be great. He's probably, I don't know if you're speaking to Michael Wright as the RACG president, but he's done that research. So probably the last one is what happens in Australia. Like what often happens is we have overseas doctors. They come here. They actually can't work in the cities. They go and train in the country, and then they go back to the city. And look, that is partly a workforce solution for the country, and I get that. but I can tell you that the supervisors are not appropriately remunerated for that. That's a subsidy. The rural communities and rural doctors are really, I mean, the payoff is they get a workforce solution, but they're not really subsidising the time and effort. We have a lot of Australia has amazing rural doctors, right? It's amazing, capable rural doctors and GPs and rural generalists, and they are putting their passion and time, pouring their passion, time and effort of these doctors, and then watching them go back to the city, right? And that's a sort of a subsidy I think rural doctors are making to urban doctors, and it'd be nice to see through the PIP payment. We get quite a good PIP payment for medical students. It's $400 a day. You can do the maths. Can be $2,000 a week. That's a very good payment to look after a medical student in your practice. We would like to better access that for these trainees that sometimes need more training than doctors in urban locations.
Is that payment going to the practice or to the supervising doctor?
Goes to the practice, but the practice usually then pays it to the supervising doctor. Yep. So I suppose that's really that's probably enough from me. You probably want to ask me some questions. I could carry on, but I'll save you. I'll save you.
Thank you, Dr. Senator Colbeck.
Thanks. So, I mean, you obviously got a lot of experience with what you're doing in my home state of Tassie, Flinders and King and Queenie and those places or Flinders and King Island in particular, have remoteness issues because of the patch of water. So what are the fundamentals of how that works? You're effectively running the MPS for the state government, so you're running the hospital?
No, we're just supplying the medical staffing.
You're providing the staffing into
medical
those
staffing
facilities.
for inpatients and emergency department for the state government. So it's a contract. They do everything they normally do. They have the admin staff, the nursing staff. Our doctors have to follow the THS procedures, policies. We are running the general practice. Mm-hmm. We employ the receptionists and the nurses in the general practice. Then our doctors are on call for the hospital. So it's sort of what the solution. The problem we have, what we used to have in the 1950s and 60s, a doctor would come to a rural town, settle down, and they'd work for 30 years. So the solution we're back solving is that doctors don't necessarily want to do that anymore. They might want to come for 1 year, they might want to come for 5 years, they might want to come for 10 years. They may want to come for 20 years, but they don't want to take on that responsibility of having the long service leave. They don't like the idea of not being able to exit, because if they exit, the whole medical service for that town can collapse, and that's a big thing to hold on their
you're
shoulders.
providing a structure that provides the continuity that existed under the old way of doing things, if you want to put it that way. So you're providing a structure that creates that continuity because that contract is there, if you like, with you from the state government to continue to provide resources, human resources, into the system, whether that be the GP practice which you operate, or also to the hospital with some crossover.
Yeah, well, it's complete crossover. So Flinders Island, you've got Alex and Lynn there, and probably another doctor who I've probably forgotten their name. Sorry, but they are on call for the hospital. Yeah, so they provide GP service in the practice, and they're also on call for the hospital, 24/7, 365 days a year. And then if they go away, we have to provide locum support and put locums in to cover their gaps, right?
So in terms of the GP practice, which is the sort of more specific element of what we're looking at, although the concept of bundling is something we've spoken a lot about through the hearings that we've had. In terms of the GP practice and the Medicare payment system, how does that go to covering the cost of running the GP practice, and would there be a proportion of the cost of the GP practice that's being met by the state through the contract?
Yeah, look, it works. It's more financially viable as a bundled model. Small general practice is of, say, 2 or 3 doctors is not particularly viable. For us to operate it as a, I mean, it can be viable if you're owner-operator, so I'm not saying that you can't run a 2 or 3 doctor practice and make it viable as an owner-operator and working in the practice, but to not work in the practice and make it viable, small rural practices, we really do need that state contract, correct? Yep.
Yep. So in terms of that, what proportion of your overall costs is being contributed by that state input?
Well, you know, it's probably 50-50, roughly. I mean, it'd vary from town to town, but it may be 50-50. Maybe we're generating 50% of our revenue from Medicare billings and PIP payments, so maybe we're generating the other 50% of revenue from our hospital contract. Yeah.
Okay. So I'm trying to compare it with some evidence that we got in Queensland from Queensland Health a couple of weeks ago, where they were saying that the MBS items probably covered about 75% of the costs for them to operate those services out in those remote communities where it was bundled, and they were doing a similar model but basically managed through Queensland Health, and you talked about them having a different model. So I'm just trying to get a sense of where the resourcing of the system sits in terms of its financial viability to actually provide, and what top-up is being provided from other sources to make it work.
Oh, well, yeah, okay. The Queensland model is different in that you're often an employee of Queensland Health. Yep. Right? So that's the difference.
Yep. No, I understand there's different models, and so I'm just trying to get a sense of the proportion that's having to be put in from other sources rather than the Commonwealth's primary health funding to make something work in a particular location. And so I talked to local...
It's hard for me to do that analysis. You could do that analysis, but you'd have to take it offline. And of course, remember, in Queensland Health might be doing predicated on having a 19.2 exemption and using that GP item number to bill for things in the hospital that we can't necessarily bill for, right?
Yep. Okay. Yep. Okay. You talked. What was the other point I was looking at? The integration of IT systems. You know, we had some conversations earlier in terms of the siloing, if you like, of the different systems. Does your model, say, in those remote communities, actually assist in that, or is it more that the personal knowledge of the people operating the system take things back?
No, it does. We have. You know, we can set up our database up at the hospital, so the GP, when he goes to the hospital, can can also look back at the medical record in the general practice. So that's something we can do. We can also provide telehealth services to these communities, but the difference about our telehealth services is that they can actually access the GP record. So you're getting, it might not be a regular GP, but you can see a GP that can see what your GP has written and see all your specialist letters, see your medications, see your allergies, whatever.
So it's a function of the model, but a beneficial function of that bundling model.
Yep. I mean, we can. It's a sort of single employer. It's a private single employer model. I mean, I get general practice is hard to deal with. You know, there's 7,000 GP practices in Australia. There's only 6 states and 2 territories, and there's if you want to deal with PHNs, there's 34 of them. But really, fundamental change and really is going to, or the best value change that you can probably make is actually to deal with directly with general practice, rather than deal through, rather than task, other parts of government or other agencies to deal with general practice. I mean, general practice is efficient. It's probably the most efficient part of the healthcare system. And I think the danger of some of the reforms and some of the direction of general practice is going to make it a lot less efficient over time. But on the technology thing, remember the US has the 21st Century Cures Act. I'm sure you've probably heard about the 21st Century Cures Act. That has fundamentally changed, the technology landscape in the US. You can. That's all based. US hospitals use FHIR, F-H-I-R, and that's a system developed in Melbourne. It's not not as widely as it's used in Australia. It's probably more widely used in the US. That's how they communicate patient files in the US, and that's how, if you get admitted, say, to a US, you get admitted to Cleveland Clinic or whatever, you get admitted to hospital. If you're the designated carer of that patient and somebody's writing in the notes, the doctor's writing in the notes, you can watch in real time as the doctor's writing in the notes. That's not recent. That's not hot off the press. This was happening, years ago. So that's become but it's only come because government. It didn't cost anything. It didn't cost the Obama administration anything. Well, it cost them the drafting of the legislation, but it really didn't cost them anything. They just mandated that the technology providers had to talk to each other and had to talk to patients. The Australian government could do the same thing. It's ironic that we have been leading the world in these systems, but because we haven't mandated the use of these systems, we're now falling behind. Right?
So it's fragmenting because everyone's developing their version of how to save the world, if you like.
Yeah, and
nothing talks to each other.
And people are sometimes going out and spending lots of money to make their product fire compatible, but if the other person hasn't made their product fire compatible, well, you can say, well, I spent all this money to make I can't communicate with them, right?
Can I, on that, Dr. Gillis said earlier about my health record going some way on that, is that not, am I totally different? There's no harmonisation that won't do it?
Look, there's probably been some improvements in my health record. It has obviously, it has been a difficult process, my health record. It probably tried to be all things to all people, right from the get-go, which is, not a great way to start an IT project. But yeah, look, I mean, I can't tell you how well FHIR is embedded in my health record. I think this is more about, there's lots of smart people in Australia building stuff, creating great stuff, but they need to be able to talk to each other. Yeah.
So it's actually a standards-based process, really. Yeah. If you have, whatever it is you're doing has to comply with this standard, which makes them compatible. Yep. It actually makes the system easier to meld. And in
the US, they said you've got 5 years, 10 years to do this.
Yep.
And if you don't, here's the fine. And they actually put out a few grants to get people up to speed. But now we're in they've flipped over now. And if you don't do it, you get fined, right?
Thanks.
Sounds good, Chair. You want to make that policy?
Yeah, let's do that one too.
That's good.
2 deals today.
Done. Okay. Thanks, Chair. A couple of very quick ones, Doctor. How do we get the doctors out there in the rural and remote regions and keep them there?
Well, I think that was at the very high level. Does government have a regional development strategy? We have things like Tax Zone A, Tax Zone B. I think I lived in Tax Zone B, that's in Burke. Tax Zone B, I think that was designed 70 years ago.
Still in Burke?
No, I'm not still in Burke, but I used to live in Burke. And I think you get about, no, I live in Sydney now. So I did 5 years from in Burke, and then I went back to New Zealand for a while, and now I'm back in Australia. So Tax Zone B, I think you get a $57 rebate on your tax. So probably people don't know about it, don't really appreciate it. It's probably not fit for purpose after 70 years, right? So I don't know what the government thinks their regional development strategy is, but that's critical if you want to look after these communities. Doctors are part of communities, so these communities have to be optimistic, have to be thriving, have to be doing reasonably well to get doctors out there. The second thing is, who's going to supervise them? Doctors can train out in these environments, but who's going to supervise? Are you willing to really pay for the supervision? We pay urban doctors to supervise because they get on the AGPT program. So most urban doctors get some sort of funding to supervise. The ones that don't get on the AGPT program apply for the FSP program. And they don't get funded, right? And they often go to rural locations. So we have to help fund the supervision of these doctors, right? And then, so that's, I think, a bit ironic. I think The other thing is that what I was saying is that people want to work, there's this part-time idea of people working part-time portfolio careers. So how do we create that in rural locations? How can we mimic what the modern workforce wants? I mean, we can try to change societal trends, but good luck with that. I haven't had any luck with that. I don't know if you've had much luck with that, but you know, how do you, you know, can you create portfolio careers? Can those doctors get involved in teaching? Can they get involved in research? Can they get involved in doing some of these things your previous speaker was talking about? You know, doing, you know, we have doctors in, say, Huonville, this place you'll know. You know, doing. It's just out of Hobart, Huonville, but it's a rural town, and it's a lovely spot. And they do use AI to do cardiac echoes. So the GP's doing cardiac echoes directed by AI. You know what I mean? So these things that you know, people, doctors find that exciting. If you would, you need portfolio careers, you need academic appointments, whatever. You need to make the job. You need to give the job interest and status.
Very interesting.
People. It's not all about the money. People kind of, throw more money. Well, we don't really want, these rural towns to be just seen as a place where you go and dig for gold and then exit. That's not really what we want. We want them well remunerated. True, we want them to acknowledge that this is a hard job and it's an important job, and they do extra hours, and we want that time and effort rewarded. But that's only part of the story. People do it because it's professionally rewarding, and they can have a portfolio type career.
It was a very, very magnificent answer. I sound like Donald Trump using those words. I think that's right. You know what I mean? Anyway.
Other people are giving answers. That's the best answer.
That was very wide range.
You've got that down. You've got that down.
It's Friday, mate. We've had a long week. That's fantastic. Any other funding streams you could suggest that we need to access to make it more attractive for the doctors to get there and stay? I mean, you covered a lot there.
Yeah. Well, we kind of back of a bare map. We thought 20 million might be directed through the PIP program, might be the sort of quantum of funding that might help us do across Australia wide. Do super
to expand PIP to the FSP people or the
FSP and maybe Acram Independent Pathway. Maybe not RVTS, because RVTS have their own funding stream, but definitely the ones that don't have a funding stream. There's also the pre-fellowship program, PFP. There's a lot of acronyms, and I'm really
should try being on different committees where each acronym means a different thing in a different committee.
Some of the same acronyms.
So I suppose there are some risks, going around. It's that sort of idea that rural becomes, the urban standards get applied to rural medicine. There's, there is potentially a push to say, well, to admit patients to a hospital, you have to be a fellow GP to admit a patient to a hospital, and I can see that that's. I see that's motivated for the right reasons. They want good care in hospitals. They want doctors to be properly credentialed with good qualifications. But remember, we're training doctors to be GPs. That's not really the bar we want for, some of those doctors will be very good in the hospital. Some of those doctors won't be good in the hospital. But to have a blanket rule for all rural and remote communities that you have the fellowship qualification is actually well-intended quality improvement, but it's going to make it quite hard to deliver rural medical services. So you see some of the binds that we're in that rural space.
No, got you. My last one, because I can feel the chair looking at the clock and through me. Just quickly, I googled Oka Health for WA, and I've now learned how to play with AI, so I'm getting pretty intelligent here. But it says that you're not there in WA, but there was something in Australind.
That's correct. Yeah, that's correct.
Is there anything else in WA?
We don't have anything in WA.
Oh, sorry.
We used to have a couple of practices in WA, but we sold them. We sold them to Brecken Health. If you've ever come across that company out of Bunbury. Yep.
That's fine. Thank you, Chair. Thank you, Doctor.
Just quickly, you talk about careers and you talk about portfolio careers and stuff like that, but in your submission, I think you're also talking about amenity. I think it's very important for doctors and families as we go forward too. If I look at, you mentioned Dubbo. Dubbo and Orange, very similar technology hospitals, both rural hospitals, both same health district. One has hundreds of specialists in it, one does not. They're both Sydney Medical School thing. The amenity is important for these rural zones too, aren't they?
Yeah, I think so. Look, I mean, let's go to a little town, Warana. You know, it's a town of, say, 1,500 people, you know, in the northwest of New South Wales. I mean, there's a cafe there called Muddy Waters Cafe. If you go there at lunch, you'll meet everybody in town. You'll talk to the mayor. You'll talk to whoever. You'll talk to somebody from council, somebody from the Lands Council, somebody from the whole cross-section of community will be at the Muddy Waters Cafe. Now, if that cafe closed, you know, that would be a big blow to the town's amenity. You know, so the amenity of these communities is very important, and that's why I'm saying that there needs to be thought about how to make these communities thrive, because these communities are, doctors are just, our health workforce are just human beings who want the same things as everybody else wants, right?
Thank you.
Yeah.
Okay, thank you for your evidence today. I don't think you've taken any questions on notice, but if you do, please provide your response by Friday the 11th September. We'll now pause for a quick break and return at 11 a.m. Thank you. Rightio. I now recommence, and I now welcome Mrs. Peter Rutherford from the Rural Doctors Association. I understand that information on parliamentary privilege and protection of witnesses giving evidence to Senate committees has been provided to you. Is that correct?
Yes.
Right. For the Hansard record, will you please state your name and your capacity in which you appear today?
I'm Peter Rutherford. I'm the Chief Executive Officer of the Rural Doctors Association of Australia. The Rural Doctors Association represents the interests of rural doctors, rural and remote doctors across the country, predominantly focusing on modified Monash 3 to 7 communities, and doctors, I guess, that live and work in these communities.
Okay. Do you have an opening statement you would like to make?
I guess just to flag that we are unapologetically rural, so we're very grateful for the inquiry that's been set up, and we thank you for that. Our remit is all about increasing access to improve health outcomes for people living in rural and remote communities. So we try and be solutions focused, and there is a broad range of initiatives that are in place. There are some that we find are encouraging and have some really positive future trajectory in them. There are others that we would like to see changed. And yes, just grateful and happy to take any questions. And we've made a submission, and we can expand on that. I guess just a little bit about me as well. I've been in this job now 10 years, so I'm quite familiar with some of the challenges, but previous to that worked for Queensland Government managing small rural hospitals, including primary care services, aged care services, and prior to that 10 years with Medicare.
Okay. One of the statements you make, and one of the things we're addressing is the adequacy of Medicare support for mixed team models, and we're hearing lots of things about the difference between block funding and activity funding, where there is failed markets or thin markets. That is a real key for us. What is your general thoughts on that?
The Rural Doctors Association for a long time has held the position that the fee-for-service model of Medicare on its own is broken and is no longer fit for purpose for rural and remote practices. We're certainly being supportive of the opportunities to explore block funding models. We do warn government that they do need to sit down with practices and people that are at the forefront to really test some of their theories and assumptions, because we worry that sometimes sitting in a Canberra bubble, you can crunch the numbers, but that's not how it works at the coalface. And what we are aware of is that rural and remote practices have become more and more reliant on the various incentives that are available to those practices. But to access those incentives, and a lot of the submissions and reviews have talked about this 60-40 split, where 60% of GP revenue is in rural communities is the MBS, and the 40% is other grants or incentives that contributes to the funding. And that's true. What we would say is that that's not necessarily then the goal that should be applied to metropolitan centres. It may be an indicator, but for that 60-40 split, rural doctors have to work really hard to access those funds. They have to do after hours, they have to do often procedural work. They're providing residential aged care visits. There's a lot that goes into that. And in rural and remote communities, there's nowhere to hide. So it's different in metropolitan, where if, doctors have elected not to do residential aged care, they're not going to get bailed up at Coles when they go shopping and asked why. I can tell you in rural communities, you get bailed up at the IGA and asked, why are you no longer seeing my mother or my father, or why aren't you doing this? So there's nowhere to hide in rural and remote communities if you want to just focus on the more, financially rewarding aspects of general practice. It's pretty much you're in there and you've got to provide the full scope of GP type services. And often in these communities, to have a sustainable medical workforce, you are reliant on having doctors, GPs and rural generalists working across not just the general practice environment but also the hospital environment.
In Queensland, in Brisbane, we heard a lot of evidence about needing stress test decisions for regional and remote areas before they're implemented on that very similar thing versus the bubble. What is the intended consequences versus stress testing what the actual consequences for regions are? Do we do enough of that?
No, I think we continue to look at metropolitan arrangements and then try and fit the square peg into a round hole. I think rural doctors and remote doctors are probably more inclined to innovation, more open-minded to innovation, and are willing to try things. They will sign up, they will, do things. They're very much community-minded. They know their communities well. But again, I still think that even taking a solution that works in a rural community and trying to then force it into metro doesn't work either. It really is about targeted solutions, and that, it's okay that the solution doesn't have to fit every environment, because generally it won't. A good example of that at the moment is the pilots for single employer model, which the previous speaker mentioned from a private perspective, but certainly the pilots that are utilising state employment, they work really well in rural, and that's mainly because the medical workforce is often shared between general practice and the hospital. So the states are willing to take a bit of a financial risk, and there is an element of financial risk with the model, but it's a lot cheaper than, them having to then pay for locums if they don't have doctors in their community. So it works really well in the rural context, because there's a benefit for the state and there's a benefit for general practice. But that model probably wouldn't work in metropolitan areas, because GPs aren't really working in the hospital system in those areas. So a different type of model may work, but that's to be discussed, and certainly not something that we're focused on. But we are very much focused on the single employer model in the rural context, and it's not for everybody, but it's given people a good soft landing into general practice. Some elect to stay on it and some elect to come off it, and for various reasons, but it's certainly created a positive consideration for junior doctors when they're thinking about where will they work, what will they do, and it's allowing them to continue to accrue all of their entitlements as they continue to provide care to public patients as well as private patients in a general practice.
One of the things I'm thinking about when we're talking about the way forward and the recommendations and all this is where there are thin markets, where there is market failings. I'm loath to recommend something that goes as a broad brush across all rural and regional Australia, because there are some where there are doctors and private markets doing quite well, doing their things in community. It might not be in 5 or 10 years' time. I don't want to wipe out the rural generalists who are doing that by doing that. What sort of bar would you look? You wouldn't look for a mixed model. You wouldn't do an MM model, 5 to 7. You would just do where there are failings. You can come up with a different funding model or a different structure, would you?
Yeah, I think it has to be place-based. I think that's the really key element to this, and also with an understanding that things do change. So I think there also needs to be an opportunity that if circumstances do change, that there is a method to come in and come out. And I'm aware of, within Queensland, a lot of the time Queensland Health owns the infrastructure of the building, and at different times they will be responsible for the general practice care, and other times, depending on which doctors are coming in, it may be someone who's a little bit more entrepreneurial, has a vision, has skills, has connections, and are able actually to build a team. So I think we've got to be careful of set and forget, and that there can be opportunities to not just continue to do the same, but actually provide more.
Cool.
So in terms of that place-based conversation, which I think is actually spot on, what are the measures that you should apply to that? I mean, all we hear about is bulk billing rates and all that sort of stuff, and for where you can't access Medicare services, that doesn't mean a thing in some of those regional areas or remote areas. What should be the measures of how that works? And that goes with a different approach to the place-based element. So how do we apply those measures? Because if there's no access, bulk billing doesn't necessarily mean anything.
Well, I think, for rural and remote community, particularly remote and very remote, they've always had the highest rates of bulk billing. So tripling of the bulk billing incentive hasn't really done a whole lot more. I think, for the scope of practice in general practice in rural and remote areas is quite different in many circumstances to what's available in metropolitan areas. And, reading online comments about, well, yes, it's a bulk billing practice, but my biopsy wasn't bulk billed and this wasn't bulk billed. And we see that a lot in rural practices because the breadth of services that's available in there is quite different.
Bloods used to be bulk practice, but they're now not bulk billed.
Pardon?
My bloods were bulk billed, but they're no longer bulk billed, for example, for certain conditions.
Yeah, and that may be something to do with the pathology company as opposed to the GP, and it may be that arrangement as well. So it's, there's varying aspects, and I think there's been, looking at the data that was released 3 days ago, the PHN levels of bulk billing are still, relatively the highest in rural and remote. PHN's the exemption. Tasmania's not above the national average, and the country WA is not above the national average, but pretty much all the others are well above the national average. And I think, again, it's, a lot of practices have signed up to this, but I think the question will be whether it's sustainable longer term, and particularly we still get feedback from our members in relation to that thing of, I thought you were a bulk billing practice, but now you're charging me for this. So there's still some understanding and communication issues there. Where that threshold is, I think we do have to be careful with that. And I'm not sure we can set an exact science to this, but we do have PHNs, we have obviously, local health networks or HHSs, whatever you want to call them, for the state government. I think the community has a fairly good understanding of where they are in market failure. They will know. They will see the writing on the wall. And I think they're, through whether it's workforce agencies, PHNs or whatever, there can be a trigger mechanism. But every location is slightly different. And, not having a GP for, 6 months is terrible. But that may not be, if no one has actually actively recruited, and I've been a hospital manager, we always said the day a doctor arrives is the day you plan them to leave and you never stop recruiting. But we do see, where people have given notice, they've told people of their plans, and the local management, for whatever reason, didn't go to market to recruit. And then all of a sudden they're confronted, our doctor's leaving, and they're up in arms. And it's like, well, what did you do to support this person and transition? And, one of our members, it's a young doctor and she's very wise, talks about guilt is not a retention strategy. but a lot of the government at a state level and that are relying on, that these doctors will not stop providing care to their community because they don't want to leave the community without someone. And they're almost relying on that guilt and that connection to community to continue the health service, and it's not fair to community and it's not fair to the doctors.
So in terms of the grant elements that you were talking about with Senator Cadell, I'm curious about, rather than just the MBS items, some bulk grant. I hate to use the term grant because I think it actually needs to be more secure than that, if you like.
Yes.
So some block style funding that can have some surety to it, and the value or the scale of that. What can you say to us in terms of that? Because that can be the difference between something being there and not. And there's plenty of communities that are doing it, or the council's providing a house or the doctor's surgery or something like that to make it happen, and so there's a lot of money going in that sense. But block funding to allow a number of services to work together to provide a service where there might not otherwise be one.
I think block funding, like that is an absolute key, and the security of that funding is essential. I mean, a lot of PHN funding will be based on 1 to 3 years, depending on where it falls in the cycle. I think the other part of it is looking at, particularly for some of these smaller communities, how do you bundle aged care and NDIS funding into that as well? Because for, say, a GP practice to recruit a physio, they may only, for general practice purposes, need a physio 1 day a week or 2 days a week. Trying to recruit a physiotherapist into a town like, Quilpie or Augathella. Sorry, I'm a Queenslander, I'll use these as references.
Yeah, Warren the last time.
It's really challenging. Like, no one's going to move for, a 3-year appointment that's only going to give them, 0.2 or 0.4 of a job. Bundle everything up where you've got security of funding, and all of a sudden now you're actually working across the 3 sectors, and, it's the equivalent of a 0.6 or a 0.8 job. Yep. Now you've got an option in relation to how you could recruit, and the level of bureaucracy for to provide services for my aged care, NDIS and general practice and the hospital. For a small general practice, it's a huge burden of administration. Like, it will cost them more. Like, it'd almost be a full FTE to deal with all the reporting and all the application processes. So that part of it, where if you can look at block funding in those circumstances and how do you bundle that up, that is gold. And the longevity of that funding as well. They're not necessarily going to stay forever, but they're not going to come if the job's only available for a year.
So how do you structure the process to support that without the burden? I mean, I've sat on both sides of the table
digital
here.
Systems.
Yeah.
And again, I worked for Medicare 20 years ago, and they're still and Medicare was around a long time before that. They still use the same system. We've got lots of comments about things that can't be done because of the limitations of the Medicare system, like the computer system. We are almost limited in policy and initiatives.
We're holding ourselves back.
Yes,
by not
absolutely.
Bringing it up to.
There is so much more. I mean, the thing around scope of practice review, there was so much commentary on, integrated models, and certainly from a rural doctor's perspective, we look at, to get the best outcomes in primary care, you have to have multidisciplinary teams. They need to be accessible, but they need to be providing comprehensive care, and the teams need to be integrated. And you can only do integrated teams if you're either co-located or if you've got IT systems that connect.
And the data out of the IT systems can provide can provide a level of oversight into what's actually occurring, and anomalies in the data will show up where things are not doing what they should do.
Yeah, and even things like, duplication of care or, and particularly for rural and remote patients, if you're referring someone off to an orthopaedic surgeon, and depending on how the direct referral recommendation gets implemented, a patient could have been sent off to have a consultation from an allied health provider as well. You could be ordering the same bloods. There's a whole range of, issues that happen, and, improved IT systems will fix that. I mean, again, there's very smart people in this world, in this country, that can do it. I mean, we create an app for everything, and yet somehow we're still stuck in, the early 80s for our infrastructure, our IT infrastructure for the health system.
That'll scare the living suitcase out of a minister somewhere about the cost of building that. But anyway, that's their problem, not ours. But I agree that fundamentally is a limiting factor for us all.
Well, it's limiting, but it's also costing us a lot. And again, through various consultations, when you sort of say, well, how much did this cost? And they're like, you don't want to know. So the cost of programs are actually, I don't know, the cost of what it takes to make enhancements to the system. What I do know are astronomical, because I've been told at different times it'll cost us as much to get the system to cope with this as it will to deliver the program. So it's, the costs are continuing to escalate rather than invest, she who buys one, buys once or buys cheap will buy twice type thing. So you buy something once, invest in it properly, and it will last you a long time. But if you keep doing, Band-Aid fix-ups, it's going to continue to just keep blowing out the costs. And in the end, we'll look back in another 10 years and go, well, had we invested here, we would have saved a lot of money.
If you'd retold the whole roof once, you wouldn't have had to replace each tile one at a time.
Exactly.
Okay. Thanks, Chair.
Yeah, a couple of quick ones if I can, Chair. Thanks, Mr. Rutherford. A rural generalist. Okay, so I just want to ask around there, how are they trained?
Well, there's 2 colleges. So there's the Australian College of Rural and Remote Medicine, who only train rural generalists, and then you've got the Royal Australian College of General Practitioners, who train GPs and rural generalists. There is multiple funding sources, mainly through the Australian General Practice Training Program.
Oh, really?
I guess the basic part of it is that they'll do the intern year, a hospital consolidation year, around 2 years sort of in a rural environment plus an advanced skill. And there's, I think, 11 accredited advanced skills. So obstetrics is the traditional surgery and anaesthetics, but then we have palliative care, mental health, child health, or paediatrics. So, there's a broad range of 11, but generally it would take 4 to 5 years to train a rural generalist from start to finish. But sometimes it can take a little bit longer. Other times doctors will come onto the program a little bit later, having done a number of years in the hospital system. So, but generally sort of in a condensed version, 4 to 5 years.
And that's funded by government?
Yes.
Part funded, fully funded?
It's not fully funded. It is generously funded through the Australian General Practice Training Program. There are alternate pathways which are funded by the individual, not funded by government. But through the AGPT, I think it's about 1,600 or 1,800 positions currently funded through that program.
Per year?
Yeah, but that's the total. Rural generalists, I think, ACRM are at about 320 and RACGP talk around about 150. Now, that's the number of training positions.
Oh, yes.
The key part of that is, do they finish and fellow, and where do they work afterwards? And do they, we're getting, for the first time in the new contract with the 2 colleges, we're aware that the department has put in a proviso that they will have to provide data for where these people are working 1 year, 3 years and 5 years post-fellowship.
Yeah.
And that's, for us, that's a really important thing. Numbers into the training program are great and they're encouraging, but unless these people are actually working in rural communities at the end of training, that's where we get, a return on investment. That's where we get true increased access to services. There is a pressure point in supervision, even through AGPT, because while supervisors are paid for the education time, they are not paid for clinical supervision. So if you've got a registrar, particularly early in their time, they do require a lot more direct supervision or support to, teach them as they go. So supervisors will be paid for teaching time, which is usually like an hour a week and things like that, maybe a little bit more, but they're not paid for the clinical supervision. And what we see is that if they're with a registrar, only one person can bill. So for that attendance, so if you've got 2 doctors in the room, only one of them is billing for that attendance. Where, say, if you're training in, say, anaesthetics or something in the state hospital system, well, the registrar will be getting paid their hourly rate, but so too will the consultant specialist that's supervising them if they're in a clinical scenario. So it's while, state need to deal with their issues in relation to, overtime and those sorts of things with clinical supervision, during the day you're pretty much getting paid if you are with a registrar as a consultant, but GPs don't get paid if they're sitting in with the registrar.
Okay, so let's just say Chippy wants to reduce his tax and become a doctor. He hasn't bitten. It's all right, don't worry about that. What does it cost to put someone through the ruralist training over the 4 to 5 years, on average?
As in, you want to train? Oh, yeah. Well, you'll have exam fees. They don't, come cheap.
Roughly, yeah.
Oh, I couldn't tell you. They are slightly different. I wouldn't guess off the top of my head.
Oh, you can't give us a ballpark? Okay.
It'll be like you'd be looking in the vicinity of $10,000 to $15,000 plus workshops, things like that.
I've got the doctor at the back going like that, and he's not indicating I'm kicking a goal.
FSP is different. The Fellowship Support Program, which is the individual funding that, they will spend in excess of $20,000.
Righto. And how much funding goes in for average each person for government funding?
For the AGPT, again, it varies depending on modified Monash model, but the information is available online. But it can be, I think, for someone working, for a registrar working in MMM7, they'll be receiving about $9,000 or just under $10,000 per term, so that's twice a year. RDAA did actually develop a calculator, which you can have a look on our website, which you can put in some scenarios and it will calculate the level of Commonwealth incentives for a doctor at various stages of their career working in a, say, MMM3 town or MMM7.
So we don't want to lose that funding?
No, we don't want to lose that.
It's very important.
Okay. Yeah, it's, I guess too, it's, the way it's designed is to recognise that registrars will have greater expenses living in rural and remote because things like courses are generally either in the cities or regional areas. So it's not just the course fee, you've got travel and...
horses. I think
horses
got to do... Sorry, courses.
Courses.
Right, okay.
So you've got the additional costs of travel and accommodation to attend those sorts of things, including exams and things like that. So there's still... And I would say ACRM's probably the best at considering the rural and remote context because that's where all their registrars are. But certainly, RACGP is probably a close second. I'd say all the other specialty colleges are horrendous.
Right. Okay. Thank you very much. Thanks, Chair.
Thank you very much. I don't think we have taken any questions on those. We're at a time just about.
Thank you.
Any more?
Thank you
very much. So if there were any more, Friday, 11th September, but thank you for your evidence. Have a good day. Thank you.
Richard, you're getting a bit slow, mate.
Yeah, you would have bitten on that.
Hey, we didn't even jump.
No.
Learned to let a few things
Okay, we now welcome both in person and via video conference. In person, Ms Margaret Durain, is it? And via video conference, we have Ms Carmen Ellis from the National Rural Health Alliance. Rightio. Well, good. I understand that information on parliamentary privilege and protection of witnesses giving evidence to Senate committees has been provided to you both. Is that correct?
Yes, it has. Yeah.
Rightio. For the Hansard record, starting in the room, will you please state your full names and capacity in which you appear today?
So I'm Margaret Deeran. I'm the Director of Policy and Strategy Development at the National Rural Health Alliance.
Ms Ellis? Is frozen? Yep.
Yeah, Carmen Ellis, Policy and Research Officer at the National Rural Health Alliance.
Thank you very much. Do you have an opening statement?
Yes, I do.
Please proceed.
Thank you. Well, on behalf of the National Rural Health Alliance, thank you for the opportunity to appear before the Senate Rural and Regional Affairs and Transport References Committee for this important inquiry into rural, regional and remote Medicare access and funding. The Alliance's message today is Medicare access in rural, regional and remote Australia needs to be prioritised. Rural Australians receive less healthcare funding, less access to care options, and as a result, on average, they get sicker, they are sicker for longer, and they die younger. Last year, 2025, the National Rural Health Alliance released our Forgotten Health Spend report. Using 2023-24 data, the Alliance, working with independent consultants, Nous Group, tracked expenditure across health, disability, aged care, MBS, PBS, DVA, etc., comparing what is spent in metropolitan Australia, otherwise known as Monash Modified Model Scale 1, against spending in regional, rural and remote Australia, MMM 2 to 7 classification. we found that annually rural Australians received between $1,090 and $4,700 less healthcare expenditure per person than someone living in metropolitan Australia. Collectively, at the population level, this equates to a yearly $8.35 billion healthcare funding gap between rural and metropolitan Australia. And this is not simply a funding issue. This figure translates into real consequences that impact approximately 1/3 of Australia's population, around 7.4 million people. And you will be aware on this committee that it is this population who are working hard each and every day in industries that are bringing in our food, our export income, and our general prosperity as a nation. And yet, rural Australians experience higher rates of chronic disease, die younger, have high rates of potentially preventable hospitalisations, and face greater barriers to accessing care. They have fewer health professionals in metropolitan areas. These outcomes are not inevitable, but they are historical. These are the consequences of long-term underinvestment, a reliance on goodwill as a workforce strategy, and funding mechanisms that are designed for busy metropolitan practices, not rural ones. Throughout this inquiry, the committee has called for witnesses to move beyond describing the problem and identify practical solutions. Rural communities are already doing their part. Communities are purchasing medical practices, building accommodation for health professionals, and investing their own resources to attract and retain workforce. But local goodwill cannot overcome systemic underinvestment. The reality remains that in Australia, your postcode determines how much healthcare you will receive. The Alliance believes the solution is to address the inequity at its source. We are pleased that all levels of government have signed up to the National Health Reform Agreement that includes Schedule F, better health equity for rural and remote communities. The National Rural Health Alliance will continue to monitor that governments are meeting their obligations to support rural communities through this schedule. The Alliance continues to believe that Australia needs a rural health strategy to bring all the issues concerning workforce, access, research, innovation together under one strategy. An immediate investment should also include a $1 billion National Rural Health Fund to strengthen rural health infrastructure and support flexible funding models where traditional market-based approaches have failed. We also need a clear understanding of what equitable access actually looks like. Our Defining Optimal Levels of Access to Primary Healthcare in Rural and Remote Australia project, if funded by government, will establish evidence-based benchmarks that reflect geography, workforce, demographics and community need. If we don't define what optimal access means, we cannot plan or fund services accordingly. The Alliance believes the policy environment is ready for this shift. Recent reforms, including Scope of Practice Review, the National Health Reform Agreement and the National Health and Medical Research Strategy, all recognise the importance of providing rurally tailored solutions. But unless we are prepared to fund rural health equitably, every innovative model, every workforce initiative and every Medicare reform risks becoming a castle built on sand. As you consider the evidence presented to you in this inquiry, we ask the committee to keep one question at the centre. Would you accept a health system that expected your own constituents, your family or your friends to receive less healthcare simply because of where they live? Or raise money from their own pockets to access services that is readily available in other parts of the country? Rural Australians are not asking for more than metropolitan Australians. They are asking for the same opportunity to access healthcare. We look forward to answering your questions and working with the committee to help achieve genuine health equity for rural Australians.
Thank you. Might kick off with a quick one. Your number one in your recommendations is about telehealth and reviewing the exceptions and the requirements for how that works in rural stuff. We're hearing a lot that that's been changed and it has an unfair burden on rural and remote people. Can you just expand upon why that's really important?
Yeah, I think telehealth, it's part of the landscape now, and it's a very important part of the landscape. Our view is that it's an addition, it's an augmentation of healthcare. It's not replacing what should be good face-to-face care, but it's an important part of the equation. And we want to see people having access to face-to-face care, but also access to good telehealth. And that means proper infrastructure for the practices. Not all of them have this infrastructure to be able to deliver good telehealth. And so we want people to have that access equitably, it's sometimes people don't want to travel. They can't travel to an appointment. So having that access to telehealth is important. But we are a bit concerned that the debate is going to the level where, well, they can just have telehealth. They don't need face-to-face. And we would draw the line at that.
Okay, that's good to know. Another point in your recommendations is about commit to full-time indexation of medical benefits. There was just evidence earlier this morning. I don't think anyone thinks we shouldn't be increasing in some way, shape or form, but there was about a different model as an independent pricing authority for that, similar to hospitals. What are your thoughts? Would that be a similar outcome that you'd be happy with?
Look, we would be open to that. I think we'd go back to first principles on this, which is we know that historically indexation hasn't kept up with the costs. And in fact, I was speaking to a practice the other day, and they're fully bulk billing now, and they've got those extra incentives. And the Medicare indexation was 2.6, I think it was, in July. Their health services award is 4.7 or something to that effect. So already indexation has been eroded by the rising costs of wages, let alone all the other transport and so forth costs. So in terms of how that mechanism is mechanised, I suppose, to track expenditure and what costs really are for practices, if it's an independent pricing authority, so be it. But our point is from first principles that the costs continually seem to outweigh indexation, and just when practices get ahead, just because of, say, Medicare bulk billing incentives, they know that that's just this year. This year we're okay, but next year, as soon as that indexation is eroded, we start going behind again.
Right, yeah. So whatever mechanism that just prevents that would be good enough?
Not good enough. It has to track the full costs. Yeah.
Okay. If down here you've got an interesting part. It was coming through everywhere. It was something I'd never thought of as part of this committee, is the information sharing and the compatibility of systems. That is almost unanimous. There's two things we're getting: is entitlement doesn't make access, and we're getting that the IT systems aren't up to scratch. That's come through in your stuff?
That comes through, and because we represent the full range of health professionals, so part of the alliance is we represent all the health professionals. We hear that across all health professions, and a part of our advocacy, we're looking at telecommunications access, digital access, which of course I'm sure you're interested in, and this is such a fundamental part of the rural health landscape. Services are spread. People are travelling to the city to get certain treatments. That communication has to happen. So you have to have good infrastructure to let that information go across health professionals. And also for continuity of care. If you've got a GP, for example, that's your core practice in a rural town, they want to keep track of what you're doing, and so they can provide continuity of care. If that information is all over the place, how can they do that?
And lastly, you speak about funding a better study through your organisation on, how we do this, how we roll out, how we equalise the underspend. I think you put the underspend about 8.35 billion-ish.
Annually.
Yeah, annually, sorry.
Yes.
I said to the previous witness, I'm not sure you're here, we don't want to go out and do the same, recommend something that is another problem and just say things that work in these rural communities that won't work in other rural communities. I think you've got stress testing or rural testing as part of your submission as well.
Yes.
In your mind, if you were to do this study, if you were to be funded to go off and have a look at what works, how do you protect where there are markets and doctors and GPs and practices and health communities that are working on a market basis, how you don't override them with a primary healthcare system, how you don't come up with a system that crushes people that are already doing things?
Oh, absolutely, and you would have heard the saying, one rural town is one rural town. But we do know certain things. And we know that the workforce, particularly as you get to that MMM5, drops considerably, and the size of those towns makes it hard to sustain the workforce. So I've been recently speaking to a couple of practices, and look, these are rough figures, but they will say that a GP, for example, should be bringing in about 500,000 a year in billings. A sustainable, viable practice, according to an accountant that does a lot of general practices, needs to have about $1.5 to $1.6 million coming in a year in their billings to make them long-term viable. Because with that billing, they've got to pay themselves, they've got to pay their staff, they've got to pay for the rent, they've got to pay for the insurance, etc. So this is just a guide. That 1.5 to 1.6 is a practice. Now, what that equates to is about 3 GPs and their staff. And I recently spoke to a GP in southwest Queensland in St George, and they confirmed they've got 3 GPs. It's working okay. The numbers at the moment on the bulk billing incentives are working for them. The minute they lose a GP, which they could at any minute, they go down to 2, they will be just crushed again. So it's that kind of thing where we know generally what makes a practice viable, and we're talking GPs here, but of course there's other health professionals as well. But we also know when they can't get to that economies of scale, that's where they can't sustain themselves. They can't afford to pay for another nurse, a diabetes educator. And then once you can't do that, you're not offering good health care. So when we're talking about supplementing and block funding or blended funding, it's to fill those market gaps. And as we will say, Medicare works if you've got a lot of people coming through in a metro practice, that's great. But we know in rural it's just not the throughput. And so there is a gap. There's always a gap. And it's those practices. We've talked about a fund that they could access because we're also talking about access to infrastructure as well. So it's the actual cost of running the practice, but we also know some of the practices are just needing to fix the roof, needing to get that IT so they can offer telehealth. And that funding is not there for them.
There's something that's just come to me which is on me because I should have asked earlier witnesses and it's just come to my head. What's the normal basis of employment of doctors in practices nowadays? Is it a percentage of billing? Is it does the money go to the doctor and they pay a service fee back to the practice for operating the practice, or does the practice get the money and pay the doctor a percentage of that, or is it a salary? What is the general thing in rural Australia?
That's probably out of my field of expertise to answer. Yeah. I would only say that I'm sure it's different, every practice is different. And of course, in some of our experience, a lot of the practices we hear about are when, let's just say a GP has retired, leaving a rural town, the local government or a community group is making that decision, do we purchase this practice? And in that case, they'll obviously have to think about salaries and how the fund, what might have been a private practice is now being owned by, say, a local government or a community organisation.
Interesting. I've seen different models. I didn't know what the predominant one is. Senator Colbeck, you have questions?
Yeah, I'm interested in the block funding model and how that might be applied, but also how it might recognise qualifications that aren't currently compensated under the MBS, but are making a critical, if you like, but let's not, a contribution to the operations of the practice. So we had the paramedics in front of us in Queensland a couple of weeks ago. I was at a practice last week where it's nurse practitioner led, has 2 or 3 GPs who are providing the odd 1 or 2 days a week each, but also a paramedic, and which is allowing them to effectively operate almost urgent care clinic type processes, but there's no compensation for the paramedic within the facility, and yet they're clearly making a valuable, critical contribution. So how do we account for those things within our support for those practices, or does that become part of the way we consider the block funding?
It's such a fundamental question, and that's why, like the Alliance, we developed a model which we call PrimHS, which is to implement a model that is, block funded plus Medicare billing, because we kept hearing from rural practices that they want to employ a multidisciplinary workforce, they just can't afford it. And we know, of course, chronic diseases are higher in rural populations. Things like diabetes educators, physios, paramedics, if that's what's required. The Medicare funding just doesn't allow for that, because often it's GPs who can do the billing, and there's some, obviously there's other billing arrangements through Medicare, but it's not enough for those other health professionals. So a block or blended funding model is probably the only way that you can get the income so that you can employ a multidisciplinary workforce. There is the Workforce Incentive Program, the WIP, which goes some way, and it's rurally loaded, which is good, but talking to practices, it's still not enough. They still have to have a big enough economies of scale in their billing to get that and enough extra funding to employ the workforce that they want. And, you know, I've heard GPs want to have that workforce. They want to be supported by nursing staff, allied health staff. They want it, and it would make a much better practice. But currently the MBS fee-for-service, with a little bit on top through programs like WIP, just don't go far enough.
So how do we design something that supplements the existing system in rural areas that provides that core sustainability?
Yeah. Well, actually, the scope of practice review, a massive review that's been undertaken by Professor Mark Cormack, talked to this. He's got recommendations in that report about the 60-40 blended funding, you know, that he proposes as a good model for rural. So to have billing, of course, coming through, but then a block-funded component on top. So the recommendations they're actually already there. You know, all of us advocacy organisations contributed to those reviews. You know, they're there. They're just waiting to be implemented.
So the scope of practice review process has, I think, been really good. So it's actually now putting that into genuine practice and recognising it within the funding system of the overall Medicare scheme.
Yes.
Okay.
Yeah.
Thanks.
With what's the $1 billion investment get me?
Yeah, well, we started somewhere.
Yeah.
and bearing in mind that's in the context of an $8.35 billion deficit. So, you know, obviously we were taking the approach, let's just start, let's put a figure on it and let's, you know. So I think in our thinking it would be particularly, say, MMM5 practices.
5 and up?
Yes, yeah. That would have access to a fund. Now, we've put forward a fund, but there are, of course, other models. You know, I've mentioned workforce incentive program. Like, if that was to be increased to a similar amount, but in terms of a fund, we don't want a grant that's going to run out. You know, okay, you get this for a year and that's it. A really genuine fund that those practices that are in those what we call thin markets can access and. You know, they might have to say exactly who they're going to employ. Are they going to employ a nurse and a diabetes educator? Is it part of the infrastructure? Do they need to get some digital telehealth infrastructure set up? So when we didn't get, I couldn't give you exactly numbers, how many practices, because of course it would depend on what people need. But we thought, let's start somewhere. Let's put a proposal on the table that is showing this is what we need, our practices need to access.
So that $1 billion annual fund, as it starts, would be the source of the block funding component of the billing component, or would that be different, that this would be over and above?
We put it as sort of 50-50 infrastructure and the other, so half an infrastructure fund that practice could access, and then the other 50% is in terms of employment and running the services.
Okay. When we heard, I think it was, what was the Western Sydney thing? It was 1,017 square kilometres without a GP. It was an amazing, only 1,200 people lived in the area, so it was very hard to fund a GP.
Western Queensland.
It was Western Queensland, but I forget what it's called, the area. I think it was something. There are no real answers on what we can do in an area like that, are there? It's very, very hard to get services that sparse.
Look, it is very hard to get services, but at the same time, you know, I'm going to give you an example in WA. There are a whole range of local governments in the wheat belt who've got together, 6 shire councils who've got together, and it's hard to have a GP there, but they're paying for it, and they're paying for a rural generalist program that services those various shires. Now, that's an example where it's really hard, but they've done it, and they've done it on their own bat, and they're paying for it out of their own rates, which is not what they should be doing in local government. But there's nothing there to reimburse them. So there's no magic solutions, but when people do have a solution, they should be supported. They should be able to get access to what is just basic healthcare service. And this particular group of shire councils are fantastic advocates, but they're going to the Commonwealth, they're going to the state, and everyone just keeps saying, no, not my problem, it's your problem, and they're left paying the bill, which is not appropriate.
How you came up with a number, I think it was 1,090 to 4,000, and I can't remember the rest of the numbers.
Yep.
4,000 plus difference underspend per person in MML 5 and up or 3 and up?
2 and up. We compared it to Metro. Yep.
Was that data available via the current system? How do we get hold of that data? What was it? I know that's from you, but how did you get access to the raw material?
So we worked with Nous Consultants, and we used publicly available data.
Right, okay.
So we tracked all the MBS expenditure, public hospital expenditure, DVA, Royal Flying Doctors, PBS, aged care, NDIS, tracked it all by where people live. Right. And so basically you can come up with a figure of what is spent on every single person in Metro and what's spent on every person in 2 to 7, and you average it out and you realise what is spent is a deficit.
So in Queensland, again, when we're talking to some of the distance people, they're talking about it also being a 13-year life expectancy difference on health. Does that go to that level too by the Monash levels, or it doesn't?
There is data. AIHW track this data, and I can provide that to you on notice if you'd like, in terms of but essentially you can track by remoteness that life expectancy reduces, and of course in Indigenous populations that's even multiplied. So the further you go out, your life expectancy, on average, is reduced.
We had Nacho this morning, but Aboriginality is just part of the problem. That remoteness is another key part of the problem out there, isn't it?
It's absolutely part of the problem, because if you can't access a service, if you can't access particularly primary care, you're not getting diagnosed. If you do, finally get to a service, you might be diagnosed late, and whatever your condition is has progressed to a point where it can't be treated, or things have got worse. So it comes fundamentally to access to primary care, because that's what you need. That's what you need to get diagnosed, to get treated, and if you need to go to a hospital, to get referred to a hospital.
Okay. Any more? All good? I think. What? Yeah, I know, but there was a good report. I've read the summaries. I was happy with it. I haven't got much more on it. I'm not sure. There's a lot of commonality across what we do. In a committee, when you start getting the key evidence over and over again, there's some key things that you have to. We're politicians, but we're not totally ignorant on the punch up for most things. But it's that nuance version of the individual pricing authority versus we know that money has to go up, right?
Yeah.
We know that there needs to be incentives in doing rural differently. Is it a different model overall? Is it just modifying different codes to allow more things? And there are different things that we have to do, that we have to consider. And I just think that's the nuance. We're at the nuance point right now. We're just considering that. Yeah,
which is great.
You would have heard some of the evidence earlier on information sharing and information flows. Do you have the same concerns about the capacity of the system to actually apply those things? And how do we make the system work better so that information flows better in the interests of the people we're looking after?
I'm not sure I could answer that on a technical level.
But it needs to be done.
It needs to be done, and I heard my colleague Peter Rutherford saying just before, some of the systems are very dated, very dated. But what I would say, and I think I mentioned it earlier, is if there are going to be investments to update that technology to transfer information, which there obviously has to be, that rural can't be left behind in that, and there will need to be further investment so that they can get that digital infrastructure in place. It can't be just assumed that they can do it. You know, these things cost money, and in terms of new software, whatever is required, it can't be just sort of left, well, they just have to pick up the bill, because that's where they start to fall even further behind.
I'm not sure how my GP's old index cards with paper wrapped around them and rubber bands will be integrated in the system.
Well, I mean, that's one of the challenges of the system anyway, isn't it? It's been digitisation, getting people to accept the digitisation, to trust the digitisation, and then we do a full circle round to the conspiracy of what it was about in the first place, rather than what it's really about, which is trying to help people get good health care. So there's all of those challenges, and I've seen a few incarnations of that from...
And I think the thing is, health practitioners are not funded to do some of that work. Like, it's a lot of in the back end, you know, phone calls, trying to sort things out between other health professionals, and Medicare doesn't fund that work. It's again, back to what I said at the start, goodwill. A lot of it is on goodwill.
It's purely service delivery. It's not the things that support it.
That's right.
Okay, thanks.
Thank you very much for that. You've just taken note to give one thing back to us, those numbers on that. If we can have that by Friday the 11th of September.
Yes.
With that, we shall suspend for a lunch break and return at 1:15. Thank you very much. We now resume our hearing of the Senate Rural and Regional Affairs and Transport References Committee. I now welcome Ms. Jennifer Mayhew-Larson and Mr. Michael Frost, representing the Australian Institute of Health and Welfare. Welcome. I understand that information on parliamentary privilege and protection of witnesses giving evidence to Senate committees has been provided to you, correct?
Yes, thank you.
Thank you. For the Hansard record, will you please state your full name and capacity in which you appear today?
Jennifer Mayhew-Larson, Unit Head of the Medicare and Analytics and Pharmaceutical Analytics Unit at the AIHW.
And I'm Michael Frost, the Head of the Primary, Community Care and Information Standards Group at the Institute of Health and Welfare.
Thank you very much. Do you have opening statements that you'd like to make today?
I do, thank you, Senator. So the Australian Institute of Health and Welfare thanks the committee for the opportunity to appear today. We would also like to acknowledge the Ngunnawal people, the traditional custodians of the land on which we're meeting, and pay our respects to the people, cultures, elders past and present. We also acknowledge all First Nations people who may be here today. As Australia's National Agency for Health and Welfare Statistics, the AHW has almost 40 years' experience collecting, analysing and reporting data to inform decision making. Our role is to provide independent, high-quality evidence and to work collaboratively with governments, services and researchers to strengthen the national evidence base. In our submission to the committee, the AHW highlighted long-standing disparities in access to primary care, specialist care and mental health services for people living in rural, regional and remote areas. Since providing that submission, we've done additional analysis of Medicare's benefits schedule data and will provide the committee with a supplementary submission, updating our analysis to include services provided to the end of June 2026. And this additional analysis will then cover 8 months of data following the changes to Medicare referred to in the terms of reference that were introduced on 1 November 2025. Using the data available to us, we examined those aspects of access that might reasonably be expected to change following the reforms, including service use levels and patterns, telehealth use and patterns, and also the costs of accessing primary care, including both bulk billing and out-of-pocket costs. Overall, the updated analysis showed similar patterns of service use following the November 2025 changes. GP attendance rates, specialist attendance rates and telehealth use in the 8 months to June 2026 were broadly similar to the same period in previous years. For example, GP attendance rates remained relatively stable from November 2025 to June 2026 at 3.71 services per person nationally, 2.50 services per person in remote areas and 2.15 services per person in very remote areas. Specialist attendance rates were similarly stable at 0.76 services per person nationally, 0.37 in remote areas and 0.23 in very remote areas. Importantly, there has been no clear change in the long-standing disparities in access between remote and very remote areas and more urbanised parts of Australia. These geographic differences continue to be evident across primary care, specialist care and mental health services. The clearest short-term change observed in the data relates to patient costs. Bulk billing rates increased nationally and in both remote and very remote areas following the November 2025 Medicare changes. Between November 2025 and June 2026, 85.2% of GP services in remote areas and 92.2% of GP services in very remote areas were bulk billed, with the rate in very remote areas being the highest observed or the equal highest observed over the last decade for the same November to June period. As with our original submission, it is important to recognise both the strengths and limitations of using a payment system like MBS data. MBS data provides valuable insights into patterns of service use and telehealth use, bulk billing and patient costs. However, they provide only a partial view of access to care. They do not capture information on the clinical need of patients who were treated or who were not treated. They do not provide information on the content or quality of care provided, nor on patient outcomes, nor on services delivered outside Medicare. These limitations are becoming increasingly important as models of primary healthcare continue to evolve and diversify. They are particularly important for understanding mental health care following the better access reforms introduced on 1 November 2025. While GPs continue to assess, refer and manage people with mental health concerns, the removal of GP mental health consultation items means much of this activity is no longer visible to us in the MBS data. As a result, MBS data alone can no longer provide a comprehensive picture of mental health activity occurring in general practice. That and other issues that we've raised in our submission and will reinforce in our supplementary submission reinforce the need for Australia to develop a comprehensive, nationally consistent and linkable primary healthcare data collection, which we are working on. That will provide better information on the care people receive across different settings and improve our ability to understand access to and continuity of care and patient outcomes, including in rural and remote communities. Strengthening the national primary care evidence base is critical to supporting the evaluation of Medicare reforms and other reforms in the future and for informing future policy decisions.
Thank you very much. Away from the questions from the submission and everything like that, I might get something you just said in your opening statement, something you mentioned about IT systems and information technology and linking, and the interesting phrase was something we are working on,
yes.
Because that's something that's come up. Can I ask to the extent we are working on it and what we...
So we are currently working with our partners to develop a national primary healthcare data collection.
Okay.
Our initial focus in that work is on gaining access to clinical information in GP information systems and related services like ARCHOs and AMSs. That process is something that we've been working on for a number of years, engaging with primary health networks who have access to that data and are using it, and understanding the pathways for us to use it, as well as doing some demonstration projects that highlight both things that can be done with the data and its value, and also that help us to understand the data quality, what might need to be done to improve it, and what the process legally and ethically and in governance terms will be to have a national collection formed from that information. Our current project at the moment runs for 2 years and is focusing on the harmonisation of data across 3 different extraction pathways in primary care. So there are many different clinical information systems, but there are 2 main ones. Medical director and best practice, but there are 3 extraction pathways, main extraction pathways for the data that PHNs are using. That's through the polar extraction used by Outcome Health, the primary sense extraction used by some PHNs, and the pen extraction used by others. We are now in the beginning stages of a project to work with our partners to bring that data together across the 3 and to harmonise it. So the harmonisation is about standardising the information so that it means the same thing even if it comes from a different place. But it's also about creating unique patients. So we know that many Australians use multiple practices, and so they can appear in different extraction pathways and in collections of different PHNs. So we need a process by which we can identify unique patients. So that's 2 elements of harmonisation that we're going to be working on. That project we anticipate to go for the next 2 years, and at the end of that we will have hopefully a harmonised patient-oriented data set, although it may at that point not cover the whole nation. It's by invitation, so it'll be the partners who want to voluntarily work with us, and so the national coverage will reflect those who do.
I was unaware until evidence today in reading about under the Obama administration, their mandate to use, I think, what was it called, Swift or something like that, SIXT ability, the same interface network with all individual proprietary software across healthcare so that people could talk to one another. Does that not filter down to Australia? Do we have our own developers for best practice and medical director? Is that largely not filtering through to us?
So there is a piece of work in Australia at the moment that's funded by the Health Department that's being run by the Australian Digital Health Agency and the CSIRO called the SPARKed program, and that is developing similar types of standards, very similar to that American approach, and we also know that, for example, Canada has done it as well. Yep. So there is a process like that is happening.
Great.
So where our work comes into that, to harmonise the data, we're building a data model. Yep. And so that essentially, and at the moment it's quite simple, it's available on our website, but we can provide it as part of the supplementary system if that is of submission.
It's just interesting on the way forward, yeah.
Yeah.
Because we see a lot of, I see a lot of value in what you're doing and what this is, because if we're like for like in a single piece of that, I know My Health Record exists and it's there, but something everyone can see. They were talking about a doctor in a different, if you're the primary care of someone, being able to see in real time as someone types in an update somewhere. It was amazing to me.
Yeah, so that work, the SPARKed program, will create a core set of information that must be available in that way across the system. Really, to understand the mechanisms for how they will make that so, you would need to speak to the Digital Health Agency and the department. Our part in it in terms of making a national data collection is we build this data model which sets out all the concepts of interest for research and public health and system management and policy interest.
And the extraction model from that for your models or not?
So we will engage between, and we've done some work already to understand the links between the data models that the extractors have and then our data model.
Yep.
So we'd need paths then, and then that's how we would extract the data. That will be some of the things that we'll be testing as part of that project I described to harmonise the data across the 3 extraction pathways.
Thank you very much. That's very handy evidence that we haven't had before. Senator Colbeck, do you have anything now? I've got some more, but I'm happy to go pass over again.
I was going to start with that too, actually, because my ears pricked up exactly the same point I think that Senator Cadell's did. Just goes to some of the things that you mentioned in your summary about out-of-pocket expenses and in the system and what you actually measure and what you don't. So you're effectively limited to measure what's in the MBS at the moment, and you can't measure the stuff that's outside of that, which is what you've just been talking with Senator Cadell about. Your submission talks about out-of-pocket cost patterns differ by remoteness. A smaller proportion of people in remote and very remote areas incur out-of-cost at GP attendances. However, out-of-pocket costs on non-bulk billed services are higher. My question is what you actually measure, I suppose. So is it basically just the cost at the service delivery point, or does it also measure cost to access it? So, if I've got to travel 200 kilometres and stay overnight to go to the doctor, does it measure that part of it, or is it just what happens at the practice?
Thank you, Senator. So our in that out-of-pocket cost information that we've provided in the submission and that we sometimes report as well, that is based solely on the information that is captured by the Medicare benefits schedule system. So it's only to do then with whether or not the payment is bulk billed or if there's a co-payment and the amount of the co-payment is captured. But transport costs and other costs, including foregone income, for example, to attend an appointment, that is not captured by that system. There are some indications of not the numbers, but of the effect of some of those costs in the ABS's, the Australian Bureau of Statistics Patient Experience Survey, which asks people whether or not they've deferred various different categories of care in the past year, and then asks them questions if they do say that they've deferred care on what the reason was. And so in those, some of the categories that are available there include the availability of an appointment, the time taken or the travel required to get to the appointment, and the cost. And the cost in that context is just cost. It doesn't say a co-payment cost, it just says cost. So we can assume, well, we can't necessarily assume how people are answering it, but they might be answering it by reference to all of the costs.
Yeah, okay. So is there anywhere that data might be captured that you're aware of?
The only information that I'm aware of that would get to that is the Australian Bureau of Statistics Patient Experience Survey.
Okay.
But it doesn't. What it doesn't answer is the amount of the cost. That would require, I guess, separate questions to the patients involved. There may be other people who have run surveys like that that capture that information, but I'm not aware of any.
Okay. I mean, we've talked to a lot of people who, as part of this inquiry, have got to travel a lot of distance. In fact, we're doing another inquiry, which is regional aviation, which sort of links in a bit to this as well, because for some people that's the access mechanism to be able to get to services. But pulling it all together has been, finding solutions without being able to measure the extent of the problem is not always the easiest thing to do. So, just going back to the data that you talked about with the things that have basically remained stable over that first period since the changes. Would you have expected those things to change all that much? I mean, so effectively productivity's remained relatively stable in the system in terms of the numbers that you were quoting for time per patient, for example. So productivity's remained relatively stable. The one key thing that's moved has been is out-of-pocket costs within the practice based on the bulk billing changes. So it hasn't done anything else in terms of access disparity or productivity of service.
Thank you, Senator. We are a data and statistics agency, and we largely deal with information about what has already happened. But obviously, we provided that information because it was something we thought that should be looked at in the expectation that it might change. The figures that we have to date, after 8 months? It's 8 months now of the changes, don't show any change in the service use levels. The main change that we're seeing is in the bulk billing and out-of-pocket costs information. It may be in time that those factors affect how willing people are to use the services, and service use might change, but at the moment service use hasn't changed.
Okay. In the work that you're doing around the data harmonisation, how many different data forms, I suppose? You talked about being able to get the system to try and equalise the different package types that you're getting out of various systems. And I was in the US a few weeks ago, and they were talking about the difficulty that they have over there. Each hospital has its own system, records its data in a different way. They spend a lot of time cleaning the data as such. How significant an issue is that here?
We anticipate that it will be a substantial piece of work, which is why it's that project that I described to harmonise the data is a project that will take us 2 years. We have some insight to it already, and I don't have figures to hand on this, but we have been for some time the national custodian of what's called the PIPQI data set. That's the Practice Incentive Program Quality Improvement data set. For that, we get aggregated information from the 31 PHNs that they have collected from practices on 10 quality improvement indicators.
So you'd hope they're all asking the same stuff in the same way?
So, yes, we help them with specifying the data requests and so on, but we do know, we report on this every year, usually around September or early October, and we'll be doing that again this year. But we can provide some information from those reports in our supplementary submission that will indicate the degree to which we see substantial variation through the extraction pathways. That then means it's difficult to make the PHN, the individual 31 PHN information, comparable because the extent of the variation from each extraction pathway is similar to that between PHNs. So, yeah. And they vary in their use of the different extractions across the country.
So how do you, and I suppose this is the purpose of your project, but how do you then structure the system so that you can get the least variation and you spend as little, you don't have to spend a whole heap of time scrubbing the data or cleaning the data. You can do some quality assurance on it, but then be able to get on and utilise it.
That is our aim, and that's the aim of that data model that I described to you earlier, is to, at the moment, each of the extractors has a data model that they are then using to extract data from the clinical information systems. And so they extract to that concept of interest. We will effectively have to align the concept of interest in our data model to those concepts in each of those extraction pathways to get at the right information. That might require some back and forth on specifications on how to extract the information, but that's effectively the process. I mean, it's more technical than that, and I'm not actually a technician at this, but by and large, it's about mapping the concepts that are held in those systems to our data model and extracting accordingly. That will be a detailed piece of work and requires us to specify definitions. It also means that we have made some choices in our data model. As I mentioned, it's available on our website. There's not a lot of concepts in there at the moment. That will build over time, but we're doing a subset of them to get relatively well-aligned data on that subset in the near future. To have comparable information, and then over time we will build that up. Similarly to how we've done historically, the Institute have done hospitals information by creating national minimum data sets. The process is very similar. We create concepts of interest, definitions and specifications for those, and then it is on the health departments to supply that information in accordance with that. This process, because practices don't have coding workforces, nor do they have analytical workforces, means that it needs to be more automated. So among the data demonstration projects that we've done, for example, or are currently underway, is one that is looking at the potential of using auto-coding tools to extract information from the reason for visit fields in those systems, and then codify that to both SNOMED terminology terms and ICD-11 classification terms. That would then enable us to standardise information around those things. So we're testing that, and it is going well so far.
Or anecdotal, or incidentally off the back of that, the conversation that I was having with some of the research organisations in the US was the value of our hospital data, because they didn't have to spend so much time cleaning it, so the capacity to utilise that appropriately for various trial or research processes was way easier because of the quality of the data that we have. So,
yes, that's good to hear. Thank you, Senator.
I thought it was good to hear too. The work that we're doing through the rest of the system, I think those become important as we've been hearing as to how we analyse some of those other things that we don't understand as well as we could. What was the other thing I wrote down here? No, I was going to say, so what are the key things that are not measured within the system at the moment?
So we've highlighted a number of those in our submission, and we'll draw some of those out a bit further in the supplementary submission at the moment. So there's probably there's a couple of key ones. At the moment, we have information from a payment system, so it doesn't cover clinical information or need or the reason for visit or what happens in the actual consultation that occurs. So that's one key limitation. Another key limitation is that we don't have good information then on things that are not funded by the MBS or PBS.
Telehealth, non-MBS telehealth as being an issue for that data.
Yes, non-MBS telehealth is one of those. So we've provided a lot of information in our submission on MBS telehealth services, but we put a caveat on that saying that it's an incomplete story because there is what we understand to be, although we have no data on it, are growing private telehealth services, things like what's it called, UpDoc, and services like this, which enable people to pay for services without an MBS subsidy. And it is possible for some of those to be delivered in such a way that for patients that makes sense because the appointment is available and it still costs a price that they're happy to pay. So we don't know what those data look like, what those patterns look like. So we've reported, for example, and maybe Jen could give us the actual numbers, but we've reported differences in telehealth use by regional and remote and compared to urban areas. And generally speaking, even though you might think there's a stronger premise for people in remote and very remote areas to use telehealth services, they actually have lower use of those services. Now that might be because of their preference, it might be because of internet access, or it might be because they're using private telehealth use services and we can't see that in the data. But so the numbers for those disparities are for telehealth?
Well, between November and June period, the Medicare-funded telehealth GP attendance rates only had a very marginal increase compared to the same months in the previous year. So GP attendance rates were 0.68 services per person nationally, 0.37 in remote areas and 0.3 in very remote areas. And these were very similar to the ones in the previous year.
So how do you drill down into understanding what the drivers for that are? Is there any?
So some part of that is that we would like, and this is resourcing and time dependent, our focus at the moment is GP systems, but we would like in the future to gain access to private telehealth data to be able to include that as a part of a complete picture on what's going in primary care. At the moment, we could look at the information in that ABS patient experience survey as it comes out in terms of high-level effects of access to the system, but it may not, depending on how people who do the survey answer the questions, it may not necessarily shed light on that for us either. So the main course that we would need to take is to gain access to private telehealth data so that we can have that alongside the MBS telehealth data to understand a complete picture of what's going on in that sector.
So does that inability to see extend into other elements of the private health system?
So yes, Senator. Thank you for that question. That difference does extend into other parts of the health system. Probably the key other one would be in dentistry, where we do have a data set at the AHW based on public dental services, and we are doing a project currently to improve that, but that's still only the public dental services. Overwhelmingly, we understand dental services are provided by the public sector, and we have limited information on that.
You wouldn't get...
You've been provoked.
You can't get the codes that are charged through... Oh, no, because they're all private health codes, they're not Medicare codes. Yeah,
so they're not available to us in MBS data or in our public dentistry data set.
But the health funds won't pass over the codes which they're claiming?
Sorry, what?
Health funds won't hand over the codes?
I'm not an expert in the dental work, but I don't know what processes we've gone through to try to get to that data. We do get some information on private dentistry, but it's something I think we would have to take on notice rather than risk misleading the committee.
That's fine. I do. Yeah, sorry.
And we can do that in our supplementary submission if that's of interest.
I mean, I suppose the committee is looking at Medicare, but it does services in regional areas, but it all relates. Because it's access to service, effectively, is what we're talking about, isn't it?
No, I just thought it was interesting because my wife's now a dentist, and so she'll have a billing code, and without disclosing the patient or anything like that, when it's claimed through a health fund, I think health funds would be able to disclose location and billing code by operation. But that's just me being a data nerd, so I'm pulling back a little bit from that.
Yes.
But just some clean up. I just went searching for Sparks program. Is it normal spelling of Sparks, or is there a great government spelling?
It's Sparked, SPARKED is the...
Sparked, not Spark. Okay, done. Interesting on your data, and I'll say on the record what I said before. Love the graphs. They are pleasing to the eye.
Thank you.
We talk about the lower use of telehealth regions, and that was an interesting thing graphically, but also both preventable emergency department and low urgency use is significantly higher in very remote and very remote. I'm wondering if that's country people would prefer to go and see rather than phone up someone. I know regional people. It's an interesting juxtaposition given that travel is a difficulty out there, but there's so much higher, and it's not incrementally, it's significantly higher in both of those things.
That's correct. We have reported some information on low urgency care in emergency departments in the submission, and so for example in 2023-24 people living in remote and very remote Australia had 1.8 and 1.7 times respectively the rates of lower urgency ED presentations than people living in inner regional and outer regional Australia, and 3.6 times the rates as people living in major cities. Those information, what we do to create that information is we extract ED presentations that were triaged as the urgency categories 4, classified as semi-urgent, or 5, non-urgent, from the Australasian College for Emergency Management Australasian Triage Scale. And we make some exclusions of that information that from those data for people who were taken to the ED by an ambulance or police or emergency vehicle, were admitted to hospital or referred to another hospital, or were referred by a GP. Those exclusions are to say that the person should be in the emergency department as best as possible. But even with those exclusions, really we're just using an urgency category where we don't have information that says they should or should not be in any particular form of care, but it can be a crude indication, and it is interesting that it's higher in remote and very remote areas.
And one hates to extrapolate of data, assumptions, but where there is a lack of things like your urgent Medicare, urgent care centres, Glenn, and stuff like that, where there's lack of alternatives, they may be the ED is the best place to go because there's a step up, and that might just be a different thing. Data presentation, wonderful, love it, love the information sparks. Internationally, are there similar institutes you that can be compared to that we can look at? I'm thinking regionality, probably Canada or similar things like that, where we can look at those similar outcomes? How do we compare on number of appearances, the doctors regionally? Is there stuff we can see like that?
I don't have to hand any international comparisons,
but do they exist?
We would happily be able to provide those in the supplementary estimates where we think they're relevant. So I think a typical a source of comparisons for us, given the configuration of federalism and the way services are split across that federation, is the work of the Canadian Institute of Health Information. Right. And so we'll see if there are any relevant international comparisons that relate to the hospital system. In regard to more general international comparisons, we do have some of those that we routinely do on our websites, and we can extract some of those about in terms of doctors per head of population and questions like that.
I'm interested in visits. Like, is Australia visiting doctors and specialists more than other countries, or are we less? That would be. Would that be somewhere on there?
I don't know. No, so we can take that on notice, and we can provide further information in the supplementary submission of relevant comparisons that we can find. There are certainly ones about population rates of different kinds of services and also of different kinds of professions that we would probably be able to produce for that supplementary submission. I don't know any of them off the top of my head at the moment, but the other thing to be careful about is making sure the comparison reflects the way the health system operates, because in some cases, you know, some have a different primary care configuration, and like for some, hospital is the main point of primary care as well as acute care. So making those comparisons won't always hold, but we'll be careful about what ones we put forward.
Yeah, we would just, I think, where you go and you look at these things, and as you say, like for like is so very important, but are Australia's big doctor goers and big specialist goers compared to what we are, and what effect that has on our outcome? Because from this side, we're looking at the availability, we're looking at the 13-year gap regionally on life expectancy and those health services. It would be, see if we can compare those sorts of things internationally. But love the submission. It was good.
Thank you, Senator. We will put forward some things in the supplementary submission, and also note that in terms of workforce data, the department is the holder of the workforce data, and so you may have questions for them.
Thank you very much. Anything else? No, thank you. Thank you for your evidence today. I think you may have taken something on notice. If we can have that by Friday the 11th of September, but we look forward to your extra submission, supplementary submission. Thank you very much.
Thank you, Senators, and thank you to the committee. We will provide that information by the 11th of September.
Thank you. I now welcome to the table Dr. Jason Agostino from the National Aboriginal Community Controlled Health Organisation. Thank you, Doctor. The standard intro. I understand that information on parliamentary privilege and protection of witnesses giving evidence to Senate committees has been provided to you.
Yep.
Thank you very much. For the Hansard record, will you please state your title and the capacity in which you appear today?
Yep, so my name's Jason Agostino. I am the Senior Medical Advisor for NACCHO, the National Aboriginal Community Controlled Health Organisation.
Thank you, Doctor. Do you have an opening statement?
Yeah, I do.
Go.
Great. Thank you, Chair, and thank you, Committee. I want to acknowledge that I am on the lands of the Ngunnawal and Ngambri people and pay my respects to their elders past and present. As I said, I'm the Senior Medical Advisor at NACCHO, the national peak body for 148 Aboriginal Community Controlled Health Organisations. I am a non-Indigenous rural GP who has spent 19 of my 20 years as a doctor working in rural and remote communities across hospital, private general practice and Aboriginal Community Controlled Health Services. I also want to state that I am a member of both the Medicare Services Advisory Committee, MSAC, and the MBS Review Advisory Committee, MRAC, but my comments today are as a representative of NACCHO and a rural GP, not as a member of those committees. 86% of NACCHO's 148 services deliver care in regional, rural and remote Australia, and 55 of them are in the most remote parts of the country. We deliver 2.7 million episodes of care a year to more than 330,000 people in regional, rural and remote Australia. Or to put it another way, on a regular clinic day, over 10,000 patients access our services outside of metropolitan regions. So when this committee is asking about whether Medicare works in the bush, it is talking about us. Yet, Medicare and related incentive payments do not appropriately fund the population we serve, nor our model of care. The Aboriginal and Torres Strait Islander population is the youngest population in the country with a median age of 24. However, the community has more than twice the burden of disease and it arrives decades early. As a GP, I can tell you what this looks like in a clinic. Type 2 diabetes in teenagers, kidney disease requiring dialysis in people in their 30s, and people dying of heart disease in their 40s. However, the formula that determines block funding, the standard whole patient equivalent, is weighted towards older patients, takes no consideration of burden disease, socioeconomic status, or Indigenous status, with baffling rural loadings. To support this high burden of disease, our services have developed a leading model of care, one that is rightly held up as the future of primary care, but in no way resembles other general practices. Yet we all rely on the same Medicare model. Our average service has around 3,500 patients with 12 full-time primary care staff around its GP, Aboriginal health practitioners and health workers, nurses and midwives. That team is why the care works, but Medicare is focused on the GP's time, and the workforce incentive payment, the payment meant to support this team, funds at best 3 of those 12 roles. So we build the team the community needs, and the workforce incentive pays for about a quarter of it. It is clear that our model of care disadvantages our ability to generate Medicare revenue. The review of GP incentives showed that a community-controlled service with 3 full-time equivalent GPs earns around $900,000 a year less than a mainstream practice of the same size across Medicare, bulk billing incentives and the practice incentive combined, and it gets worse the further you go from a city. Seeing patients for longer, using our multidisciplinary team to their full scope, and the distorted swappy calculation contribute to this gap. These data are a case for redesign. Medicare and its incentives were built around one model, the independently owned GP-centred practice. It's a legitimate model, and we support our colleagues' work to strengthen it in the bush, but it is not the Archer model, and when you try to fund a team-based model through a GP-centred system, the maths breaks. This committee has said it wants the future Medicare changes rural stress tested. We ask that it is stress tested against our model too. Recent changes have shown that co-design is possible. Changes to assignment of benefit and telehealth have been developed with the Archer sector and have been welcomed. So our asks are practical. Size block payments on need, on remoteness, and on that early heavy burden of disease. Let incentives flow to the organisation that carries the cost, not only the individual GP. Fund the whole team, not just the doctor, and write the rules with us with a clear line of sight to closing the gap. That will result in a Medicare system that strengthens care for Aboriginal and Torres Strait Islander people. Thank you, Chair, and I'm happy to take the committee's questions.
Thank you. A statement. Love going off opening statement stuff rather than prepared stuff early. You said your model represents the future of primary care.
Yeah.
Don't want to quiz that too hard. I'm happy to say that. Is that just in the Indigenous and Aboriginal model, or do you think for rural and remote generally?
Yeah, we think it's the model for primary care in Australia, and particularly in rural and remote, where we're having workforce challenges and we want to support people to train in their communities and stay in their communities and continue to provide care. So, you know, we've both got a workforce training model and a workforce model that supports that.
Right. You mentioned the funding of the organisation, 3 out of 12 of your teams-based model gets funding. How do you fund the rest of your operations?
It's complex, yeah. So, you know, there's core funding for it's called the Indigenous Australians Health Program that comes from the Australian government. But that still leaves a big gap after that. So our services are piecing together multiple grants. You know, one of our services in remote Australia has over 100 grants that it's navigating and managing to keep their services open. Yeah. Most of them are short-term with a life cycle of around 2 years. So huge administrative burden to sort of fund that model through multiple different ways.
Do you, I'm getting your numbers right, and if I'm wrong, please correct me, though.
Yeah.
86% rural is your by
Triple M 2 to 7, like what this committee is looking at, yeah, regional, rural and remote, yep.
How does that reflect in amount of billing, but visits or services? Are there a higher population of people in the non-rural areas? Like, would that be 86% by individual billing or MBS?
Oh, by billings?
Yeah.
That'd be hard to tell. I'd have to look at that. We actually have got recent analysis, so I could provide that if you want.
Okay. That'd be fair. So, would your non-rural nachos, clinics, and would they be easy to operate generally? Would they be more viable? Are they easier on paperwork and all the compliance?
No, they've still got really complex funding arrangements. I guess the one thing is different is that in general, they're able to bill Medicare a little bit more efficiently just because of the throughput of patients, once you start getting into remote Australia in particular, there's just not the same throughput of patients because Medicare's about throughput a lot of the time.
A very specific recommendation you made is allowing Australian Aboriginal and Indigenous to enrol in up to 3 ACCHOs?
Yeah.
That's because of travel and mob and family and that sort of thing?
Yeah, 100%. So, I think part of it is just, people away are moving between communities and, they're still receiving regular care from multiple communities. And other people are having to move between, their rural or remote home towards urban areas to receive care. So we've got data that shows about 1 in 15 Aboriginal and Torres Strait Islander people that are accessing our services, access 2 or more services in it, 2 or more separate organisations in any one year. 1 in
15, was it?
Yeah.
Okay. And the other thing that I thought was interesting, 19.2, you're saying redirect 100% of the incentives to 19.2 exemptions.
Yeah.
What effect would that have for you?
So our employment model is different to other general practice. So most of our doctors are salaried.
Right.
And that reflects a few things, but it also, in a lot of places, the Medicare revenue that the doctor is generating is less than the salary, the package that they're receiving.
Yep.
Okay. So what we wanted to do was to provide the 100% of that incentive to the practice, and then the practice under their contract with the service could negotiate what proportion went to the clinician. Right. So it's about strengthening the community-controlled element of it rather than having a direct separate payment going into the doctor when they're already, in some places, receiving more salary than the Medicare income they're generating.
Not critical of that, but thinking and just would that would require using the same model, not just in ACCHOs across the country, but for all primary health care in rural and remote, that model, if we did that 19.2 exemption? Or
19.2 exemptions largely apply to ACCHOs and to rural hospitals, not to rural general practices. Okay. In a lot of those hospital scenarios, that'd also be a salaried model. Yeah. And I guess the reason that we said that was because that when we get into rural and remote Australia, what we are generally competing against for workforce is the hospital system, and we're actually disadvantaged and able to offer less salary as it is. Yeah.
You don't have the blocks, you don't have the availability.
Yeah, that's right. Like it's just different in terms of the resources that we have at our hands. So, look, that was our recommendation. Was obviously ignored around the 100% going to the ACCHO. What we have done is that we've made it very clear that it is within the ability of the ACCHO and to negotiate it within their contract to have 100% redirected towards them. And it's interesting, some practices have maintained the 50-50 split now, and others have, with their GPs, done new contracts to redirect the other 50% back to them.
Are you having staff retention problems or any issues because of that?
Look, I haven't got it specifically regarding that issue. So it causes a lot of tension because it revolves a renegotiation of contracts with all your GPs. Some of them have been there for a very long time, and some of them know that that's not happening in other places. So it makes it really challenging in some situations. Overall, we've got a large workforce challenge. Before COVID, there was around 300 FTE, like full-time equivalent staff, vacant across all our positions across the sector, and that's gone to over 900. And that's worse in remote Australia, where about 1 in 5 positions are vacant.
So what's your full workforce equivalent?
The full workforce equivalent? Oh, gosh. It is a bit over 9,000 now. It might be getting towards 10,000. So that's thinking about, that's not all clinical, obviously. That's
but
thinking across our health promotion, our clinical services and our administrative services as well. Yeah.
So if we went to the block funding model, you're just talking about your health promotion. So you do some preventative work currently. How is that funded?
Yeah, again, by these small grants and things like that, or by using some of the IHP
So having that
funds.
continuity and size and certainty would help in...
100%. We've recently done a lot of work around funding reform for the community-controlled health sector, and part of that is around health promotion and community empowerment. And the sort of lack of stability with our health promotion workforce with these short-term stuff is a real problem, because we can't have people long-term contracts. We can't support people to stay in these positions and build a team around them to really focus on that preventative side because of the way contracts are sorted.
Thank you. Pass to...
Just a couple of things, Chair. And Mr Agostino, can I just share with you my deepest respect and regards for our Aboriginal health services in the Kimberley.
Great.
You know, not limited to Cams and Brams dams, Ngari, Ord, Yarrayungi. But in your submission, you talk about ACHOs actually being urgent care, doing urgent care stuff.
Yeah.
Now, that pricked my attention, I can tell you. Can you give us any examples where ACHOs are doing the same work as...
Oh, a lot. You know, in a lot of our remote areas within remote Northern Territory in particular, and some within remote WA, they are the health service and they're open 24/7. And so, you know, they are the first point of contact when someone's unwell, doesn't matter what hour it is, doesn't matter the severity of the injury. And so when we were doing that work around ACHO funding reform, one of our priorities was that we need to think about a way to better fund that urgent care capacity. I think we estimate, I'd have to double check it, but I think we estimated around 30 of our members are providing sort of 24/7 emergency style care. And it's, you know, Medicare doesn't fund that type of care very well at all.
And how is that different than normal urgent care clinics?
Look, I've never been inside a normal urgent care clinic, and I guess the interesting thing is that within 4 or 5 of our ACHOs in Northern Territory, they are being funded as urgent care clinics to do what they've already been doing. So they've now got a new funding model to pay for the model that they were already providing. Unfortunately, they're sort of a bit too early within the implementation of that to make me make a sort of evidence-informed comment around their success or not, but we think it's worth exploring, and we're quite interested in how those communities go with this urgent care funding.
Tremendous. And look, it may sound like a loaded question, but could you share with the committee why it's so important for these ACHOs to do this work and be funded properly?
Yeah, look, you know, I think there's lots of reasons. One is that, you know, you should get paid for the work you're doing, and this is really intense, resource-intensive work and really important stuff, because we know that we're spending way too much in the hospital system, so we want to redirect that towards primary care. I think what the urgent care clinic funding can help is that, you know, it gives people the opportunity to not drain our staff with all this urgent after-hours stuff and be able to focus on the primary care stuff during hours. Because, you know, if you've got a restricted amount of workforce, you're sort of just flogging that small amount of workforce to do all of it. And it seems like urgent care funding has the possibility, at least, of increasing that workforce and sort of separating those roles out a bit so that we can have more focus on the primary care prevention that we want to focus on.
Great. And Dr Agostino, is there any other programs in place that help the ACHOs learn how to maximise the MBS?
Yeah, so it's so we've got this program that's just been extended for a year, which was initially funded by the NIAA around, you know, better using Medicare to support our model of care. As I said, today we're here to talk about the structural things that make it difficult to bill Medicare for the care that we provide. But within that, I think there's also things that we can support ACHOs to better use Medicare that's in its current form. So, yeah, we've been running that program for a while, and it's just sort of stretching out for one extra year. And, you know, within that, we created online learning modules for people to learn about it. We've hosted a number of webinars with the Professional Services Review and the Department of Health to explain all these upcoming changes that have happened with assignment of benefit or with My Medicare. And we've also starting to run a series of workshops as well. So we're doing what we can to make the use of Medicare, but there are key structural changes that just make it hard to appropriately fund the model of care that we provide using Medicare alone.
And what are those challenges?
The changes that we want, or yeah. So look, you know, I think
this is your chance.
Yeah, great. Look, you know, I think on the general practice side, the first thing is, and you know, this is under review by MRAC, but NACHA is quite clear about this, is that you know, we shouldn't have this huge differential about how much we're paying for a GP's time like with shorter consults being preferred. You know, that was already in there before the bulk billing incentive, but then the bulk billing incentive being fixed means that it again rewards shorter consultations more than longer consultations. So we want to equalise, you know, what a patient is receiving as a rebate based on the care that they're receiving. You know, you should have the payment should just be fairly consistent across length of time. The other major thing is really about how we better fund the whole team, you know. So, you know, as I said in the opening statement, the workforce incentive payment cuts out well before we've employed all of our workforce. And if you think about the Medicare items that are accessible to registered nurses, Aboriginal and Torres Strait Islander health practitioners and health workers, which are the bulk of our non-GP workforce, they're really limited, and it's really hard to actually even make a sustainable wage doing those items alone. So, you know, it's about sustainable funding for that workforce, whether that's through fee-for-service or a block payment. I think given the nature of their care, probably improved block payments would be our preference. But, you know, we need to fund adequately the whole team. And so they're sort of the two key ones that we've raised within the submission. The other is about, the key thing is when we're thinking about these block payments, at the moment, the way that they're calculated is, it's hard to understand. You know, it's based on past use of Medicare. It takes nothing into consideration about the person's socioeconomic status or their Indigenous status or their comorbidities. So we've got data now that shows that an Aboriginal and Torres Strait Islander person accessing our service on average gets a lower block payment than a non-Indigenous person accessing a fee-for-service, like a mixed billing practice. So we've sort of got our fundamental architecture behind block payments wrong at the moment, and we need to fix that up before we start increasing block payments.
Thank you, Dr. Augustine. I can't speak highly enough of our HOs, but from the Kimberley perspective especially.
Thanks.
Thank you. Senator Colbeck.
Thanks,
I
Chair.
might pick up where Senator Steele left off. So what does a best practice block payment model look like? I mean, I won't disagree with you that the model that you have for ARCHOs is one that has, well, I think potential for regional areas.
Yeah.
But how do you define the elements that go into that to design a model that appropriately services the needs of the communities? Now, I acknowledge that there might be some different things, particularly for Indigenous communities, and you've quite effectively articulated some of the issues that are unfortunately specific to those communities.
Yeah.
But how do we design a model that accounts for those things, looks after what you're doing,
Yep.
and then some of the other regional areas which might have slightly different core needs?
Yeah, so I think when we were doing our work on funding reform, there's two bits that we think about in terms of adjustments for block funding, I suppose. One is around what is the need of the patient and what are the costs of delivering care. Okay, and in both cases, both of those things increase as we go more remotely throughout Australia. It's probably a health economist PhD sort of thing about how we determine the size of those block payments. But it's clear that the way that the payments are structured improves a lot once we add in socioeconomic status in particular, and that can just be the socioeconomic status of the region that a person is living within. Obviously getting the rural and remote loadings correct, and Indigenous status as well, because that plays within both socioeconomic status and rural and remote status, that Aboriginal and Torres Strait Islander people are in general more unwell within those areas. Where was I going next on that? Oh, I've lost my train of thought. I'm sorry about that, Senator.
I do it regularly.
What's that? Lose train of thought? Yeah. I was. So that's sort of like the fundamental adjustments that need to be made. And ultimately, we would want a block payment that reflected persons' comorbidities. Okay, but we've got a limited data system. I heard someone brought up Sparked before, you know. So, you know, that's all about the standards so that we can actually start creating meaningful data. I think ideally we would have a block payment system that did adjust based on comorbidities that patients had. But I don't think we uniformly got that system across Australia, and it's still a couple of years off. So I think at the moment, just focusing on improving block payments based on rurality, socioeconomic status and Indigenous status, as well as age and sex, is the priority. And then in the future, think about how we might tailor that to what is needed based on comorbidities.
So, in that sense, you need to continue to refine the system and the way it's applied, based on better data.
Yeah, 100%. You know, and you know, there's some real good high-quality pockets of data across the Australian primary care system, but it's not uniform at the moment. You know, and so we need to.
Well, you've probably got some better data within the Archo system than.
A lot.
Some of the other areas of health?
Yeah, that's right. So, you know, I can obviously talk about how many vacant staff I've got, how many full-time equivalent staff I've got. I can talk about, you know, the improvements we've made in type 2 diabetic care, the improvements we've made in cervical cancer screening because we submit regular data. So as part of our core funding that we receive from the Australian Department of Health, we get we have 24 national key performance indicators that provide some level of evidence around the quality of care being provided. And then we also do this other one called the Online Services Report, which is around workforce data and the number of clients we're seeing. Because a lot of the patients that we are seeing are invisible to Medicare because they're not being seen by doctors, they're being seen by Aboriginal and Torres Strait Islander health practitioners or RNs and not claiming Medicare for that consult. So we need to submit that data as evidence of who we're seeing in our population.
So that covers my next question about what quality data to make the decisions looks like, or anyway, continue.
Yeah, well, yeah, like I guess to add to that as well, you know, there was that call in the review of GP incentives around an independent pricing authority for primary care, you know, and, you know, within that structure, you know, you would get better data about costs as well, you know. I think that's sort of the thing that's missing a little bit at the moment.
I'm just trying to think about integrating these, all of the data points into the system. I mean, you're obviously engaged in the Spark program that's being pulled together. I mean, do you? We heard earlier about the disengaged nature, I suppose, of primary health and the hospital system. How do you see those things incorporating? I mean, in some communities you're effectively both, as you were talking about with Senator Still. But how do you see those sorts of things developing in terms of the actual delivery of care?
Yeah, I think it's interesting, isn't it? I've recently moved, so I spent 15 years of my life being a GP in the community of Yarrabah in Queensland. And then because of family reasons and others, I've started working a bit closer to home in Nowra on Yuin country. So I've gone from being a Queensland GP for 15 years back to being a New South Wales doctor, which is where I started my career. And the big difference in that is the viewer, okay? So the viewer exists in Queensland Health, and as an employee of an Archo, I can go in and I can see what's happening to my patient in hospitals. And I'm not dependent on a discharge summary being released. You know, I'm not dependent on, you know, patchy communication happening. I can just go in and I can see what's happening. And that's been removed from me now because I'm in New South Wales system and it's not happening at all. So, you know, people talk about improving the use of my health record, and that's obviously a key bit, and definitely that's improved a little bit. You know, I can see pathology results and radiology results straight up and medicines that have been dispensed. That's all useful. But often we really do need to be within the hospital system to see what's going on and to understand the care that's being provided, because that communication between hospitals and primary care is really limited in many areas, unfortunately.
Which makes it more complex because you've got all of the different systems that you're trying to get to work together in that sense. If you think about well, Queensland obviously has some interaction which is of value, but 6 states, 2 territories, all the different GP practice type systems, plus the MBS and Commonwealth systems, there's a fair bit of stuff to juggle there to pull into something that effectively talks to each other.
Yeah, I guess there's 2 elements to that. So there's sort of talking in real time to inform what I'm doing with that patient today, you know, and obviously Queensland has a model, you know, just to be clear, I'm a New South Welshman, I'm not, you know, supporting the Maroons or anything. Anyway, but that'll be good, that's on the hand side. Anyway, so, but, you know, in real time I can go and I can see what's happening, and, you know, it'd be great if that happened across other states and territories from my view as a GP. Then there's also about the health service planning component to it, and so that's around data linkage after the fact. And a proposal was put forward to the Health Ministers' meeting around the National Primary and Acute Care Data Linkage Project, and that's got support but is currently sitting in this sort of unfunded limbo, I think, waiting for the Commonwealth and the states and territories to determine how it's going to be funded. But for us, that really is valuable because it can then start to show us what's happening to our patients outside of our clinic room. You know, at the moment, I can see what happens, you know, at the care we've provided, what's the diabetes care we've done, but I can't see what's happening in terms of when they've left, you know, what has been the engagement with the hospital system, what has been their use of medications that we've been prescribing and things like that. So that's feasible. That just needs a commitment of funding, and we can do data linkage after the fact with the right investment.
So at the moment you are receiving funding which is notionally blocked, but it's a lot of little blocks by the sound of it?
Yeah, the
to break up. So bringing some of that together, you're getting some from NIAA, you're getting some through the Department of Health, probably some state funding as well.
Yep.
The state versus Commonwealth will stay, but the capacity to build or design a block funding model that actually meets the core needs becomes the key part of that.
Yeah, so that is the work that we've done as sort of the ARCHO core funding, ARCHO funding reform work that we've submitted to the Australian Government, the Minister of Health. So what we did within that work is that we did 10 case studies with our services to understand their real costs. And then myself and a group of sort of leading clinicians within the community-controlled health sector sort of mapped out what we think is the ideal model of care for a patient based on both their age and their complexity, so low, medium and high complexity. And then we've costed that out as per workforce. So that's the work that we did to determine what we think an appropriate block funding is. What we didn't do is that work that I said around how that changes with remoteness in particular, and with different areas of socioeconomic disadvantage. But yeah, we've done the work to sort of say this is the model that we think a patient should receive to keep them healthy and well and out of the hospital system. Yeah, and it's just awaiting a decision about changing that funding. But that would make a huge difference to our sector to have a core funding that reflects the need rather than this piecemeal that we've got at the moment.
Okay, thanks.
Thank you. Anything else? Thank you for your evidence. If we've taken anything on notice, I think you did. Can we have the evidence by Friday the 11th of September? That would be great. What we'll do now is we'll be breaking for a short break until 2:30, in which case we'll be joined by the Australian Medical Association. We're bringing things forward a little bit. Thank you very much.
Thanks very much.
Thanks. Thank you very much. We will now resume. I now welcome via video conference Dr Danielle McMullen from the Australian Medical Association. Good afternoon. I understand that information on parliamentary privilege and protection of witnesses giving evidence to Senate committees has been provided to you. That's correct?
Yes.
Thank you. For the Hansard record, will you please state your name and the capacity in which you appear today?
Dr Danielle McMullen, President of the Australian Medical Association.
Thank you very much. Do you have an opening statement that you'd like to make?
I sure do.
Let's go.
Thanks so much for the opportunity today to appear on behalf of the AMA, the Australian Medical Association. We're Australia's largest voluntary association of doctors and represent doctors of all specialties, stages of career and communities right across Australia, including the many doctors providing essential care in rural, regional and remote parts of our country. The AMA believes that rural Australians should be able to access continuous, coordinated and high-quality care from a GP-led team, regardless of their postcode. But we recognise that currently your geography does get in the way of your healthcare. Every day, GPs and other doctors in rural and remote communities are helping patients with their often complex health needs, and particularly how to navigate under-resourced and already stretched services. They're looking after everyone from babies through to older adults, people living with chronic conditions, coordinating treatment with specialists who are often many hundreds of kilometres away, and providing care for people at the most difficult times of their life, as well as managing common acute conditions and often also providing the emergency care to a community. In many communities, the local general practice is the centre of the healthcare system, including hosting, visiting other specialists. But unfortunately, as you know, where a person lives continues to have a significant impact on their ability to access timely healthcare. Rural, regional and remote Australians do experience poorer health outcomes, more difficulty accessing services and higher rates of potentially preventable hospitalisations than people living in metropolitan areas. We recognise that rural Australians need access to more than their GP. They also need timely access to physicians, surgeons, psychiatrists, paediatricians and other specialist doctors, as well as allied health and nursing colleagues. Too often, patients are travelling long distances, stuck with lengthy waiting lists or delaying care because specialist services are not available where they live, or other systems factors really not conducive to a rural lifestyle and the degree of travel they're undertaking. The AMA believes specialist care should be available closer to home whenever possible, which means we support specialist outreach services, strengthening telehealth connections, and creating more opportunities for specialists to train and build their careers in rural communities. So the solution is not a more complicated or fragmented health system, but a stronger and more viable general practice-based team. To achieve that, we do need some Medicare reforms, particularly investment in longer consultations for people with more complex needs, better resourcing of multidisciplinary teams led by the local GP, sustainable funding models for rural practices, and better integration across the primary care and hospital health systems. These reforms would help improve patient access, strengthen the continuity of care, and importantly, keep people healthy in their communities. Stronger investment in that quality preventive care will reduce that rate of preventable hospital admissions that we see. Further to that, better support for GP out-of-hours, after-hours care may reduce the lower acuity ED presentations that we see in rural areas, as well as provide better access for local communities. Another significant factor affecting rural and regional access to care is workforce scarcity, and we've long called for a growth in specialist training and employment in rural and regional Australia. We've seen improvements over the past decade in medical school and pre-vocational doctor training in regional Australia, but this does need to expand further for specialist trainees. And finally, we would suggest the introduction of a formal rural impact assessment for future Medicare reforms so that policy decisions are tested against their impact on rural communities. Thanks very much.
Thank you very much. We had, coughing or clearing my throat. You can tell me what that cough is if you want to know. It's, longer GP consultations, we heard about the effect on the profitability of rural practices where you have those complex needs, and how the significantly lower per quarter hour rebates of what they are for long things. what is the impact assessment you think that will have on, obviously a lot of these places have trouble getting doctors, it increases the profitability of these things, but will it take away the availability of doctors if we can start having more of these? Like, I'm trying to work out, do we create a problem for ourselves by having less doctor appointments, even though they're getting better remunerated, or will it help more doctors go to the bush?
It's a great question, and one that we have considered. So our modelling showed that yes, doctors potentially would see, if we adequately funded and funded a 7-tier scheme, they would see approximately 1 fewer patient per day. Right. But on balance, the comprehensiveness of the care of the other patients that you can achieve improves, obviously, the care for those individual patients, but also the sustainability of the career for the doctor. What we're seeing at the moment is in many communities where GPs are currently feeling like they either have to shift their appointment times to being shorter to churn through, like to get through more patients and to maintain the viability of their practice, or they're struggling under the weight of an under-resourced, longer consultation structure. Instead of working more, they're actually just pulling back, and we're seeing a more fractional workforce. So while this is anecdotal, we do believe that better remuneration and funding for those longer consultations, you may actually see practitioners working more per person. And so it is difficult modelling, but the impact would be small and potentially actually negated by the fact that GPs felt more rewarded in their workplace, it felt more sustainable, and they were able to feel supported to take the care of the patients that they want to, and then able to work a bit more to do that. And I think what fits in with that is if you also fixed some of the after hours challenges at the moment, you may see people, all sorts of novel things, split shifts, people juggling family and work who might do see some patients in the morning and then do a second round in the evenings if after hours were better supported. So we do push back against the claim that it will really impact access, because we think there's a range of factors where actually better supporting that comprehensive care would improve access overall.
Yep. Collectively from, I won't say everyone, but almost everyone, we're talking about the teams-based approach. You talk about the workforce incentive payments. I think you mentioned there's 31,000 per quarter. I can't remember that number off the top of my head, but it was roughly that, not enough to get the people that you need and fund the entire system. How much have you modelled what increase you think we might need to do that better?
So we have said that there just needs to be an increase. There's been work done. The government's currently been working through what was the Strengthening Medicare Task Force, and then there's been a primary care. There were a number of reviews and a group working on that primary care reforms about how we could improve team-based care. And there's a range of options, particularly when we're thinking rural and regional. Got to remember to separate. Regional is very different to rural and remote, and so probably there's not a one-size-fits-all. There are some communities, so our larger regional communities that may operate a bit more like a metropolitan centre, in which case it's still a significant increase in the WIP, but a similar structure to be able to add. At the moment, that really just covers some of your practice nurse, whereas getting some more allied health professionals in would really help those teams. There's more appetite, we understand, in regional, like outer regional and rural communities for potentially looking at larger block funded models to be able to sort of essentially block fund a practice model that included a multidisciplinary team. So we haven't done specific costings of those, but there's a range of options there.
Thank you. I might pass you to Senator Glenn Stoll.
Yeah, thanks, Chair. Look, thanks, Doctor. I've only got a couple of quick questions. And I want to go to the bulk billing incentives for GP consultations that have been expanded that we know for the first time. And we know the Medicare payments for mental health plans and consultations with the GP for all Australians now. So I'm correct, am I, that previously these incentives were limited to people under the age of 16 and Commonwealth concession card holders only?
Correct.
Okay, yeah. Thanks. Can you tell the committee, please, what impact has that had on patients in rural, regional and remote Australia?
So the Department of Health has obviously been collecting the data in terms of bulk billing rates. We see the publicly available data that bulk billing rates have increased. I haven't seen the spread of that between rural and metropolitan, but I think that would be an interesting question to put back to the department as to whether there's been a differential. We do know that, rural and regional, it varies around the country. There are some pockets where there's actually always been quite high rates of bulk billing because practices know that their patients are really struggling with affordability of healthcare, but that was affecting practice viability. Now, this, of course, improves the viability of those practices. There are other areas where it still doesn't cover the costs of providing that care, keeping the doors open, and so there are likely to still be some out-of-pocket costs. So we expect it varies by location, but would suggest that for the breakdown of kind of what that incentive has done in specific communities, the Department of Health should have access to that data.
Good. Okay. So the government, we know, has made record investments over the last few years, but particularly strengthened general practice and rural generalist workforce. So we are seeing more GPs being trained, which we've heard earlier today too.
Yes.
Yep. And do you think this will? Yep. Thanks, Doctor. And do you think this will help to address some of the challenges we're seeing in accessing GP services across rural, regional, and remote Australia?
I think so. I actually think that the two general practice colleges, the RACGP and ACRM, have both had a good rural and regional focus for quite some time now. And obviously we've seen the elevation of rural generalism as a subspecialty of general practice. So there has been a concerted effort to boost our GP workforce, particularly in rural and regional Australia, and I would commend them for that. And government has supported increased training places. We're still facing a shortage nationwide, so I don't think the pressures will disappear, but there's been some solid efforts in that space, and we think similar effort needs to go into other specialty training pathways, particularly in our larger regional centres where still you can do your medical school training, you can do your internship, but trying to complete your specialist training to be a surgeon or a physician in a regional area is still quite difficult, and we would implore, with funding for positions, both state and federally, and the colleges to really increase the number of rurally based trainees we can have.
Okay, noted. Thank you. And my last one, Chair. What impact have record investments in salary incentives, paid parental leave and study leave for trainee GPs and junior doctors and the Australian General Practice Training Program had on the GP workforce?
Had really positive feedback globally. Again, I haven't specifically broken that down to rural versus metro, but certainly had strongly positive feedback from GP registrars and potential GP trainees that the changes to paid parental leave and study leave in particular have made a significant impact on their decision to continue a career in general practice. Along with that salary incentive, now that we're seeing more doctors complete medical school later in life, often postgraduate, the salary cut that there was between hospital-based training and general practice training, especially for that first 6 to 12 months, was a significant disincentive, which we think is being managed well with that salary incentive that's been put in place.
Great. Thanks, Doctor. That's encouraging. Thank you, Chair.
Thank you. Senator Colbeck.
Thank you. Thanks for your submission and evidence. I just want to go back to the point that you made about the rural training, and you mentioned the role of colleges, particularly with some of those. How influential is that in that regional training capacity?
It is a shared responsibility. So in terms of this, there are three main players, the state and territories, obviously in terms of funding positions, and making those hospital-based training positions available. And also making sure that they're doing what they can to have a robust training environment, enough specialists, enough caseload and those sorts of activities happening there. The Commonwealth Government does have a role with STP funding, so Specialist Training Pathway funding, that there is a review of that underway at the moment, but it's a funding scheme to boost rural and regional training and training in the private sector. And then the role of the colleges is really about the accreditation of training positions and it varies between different colleges, obviously, but they do have a role in making sure that their accreditation criteria, of course, are robust but are flexible enough to understand that generalist training in a rural environment is important and high quality training and can be, and encouraging people to be able to participate in most of their training rural, and then being the other factor that plays in there is sometimes if there's trainees metro who then go into a rural placement, there's incentives, accommodation support, other supports to go rural temporarily. We do hear feedback from trainees who are based regionally that those same supports are difficult to access when they have to come to the city to do a particular block of training, and then that's obviously a disincentive overall. So there's a range of factors that could be improved to get and keep more doctors out bush.
Okay. And so, well, in the way that you've put those, they are effectively interdependent on each other as to how effective they are in an overall sense.
Exactly. I mean, the colleges could accredit a whole range of positions, but then if the state government doesn't pay for those roles, there's a problem. Similarly, the state government could say, okay, fine, we'll happily have 5 surgical trainees, but if the college isn't satisfied that there's enough of a training environment, we hit a roadblock there. Yeah, okay. So they do need to work cooperatively together.
Okay, fine, thank you. That's useful. I just want to go back to the discussion you've had around multidisciplinary team funding and sort of coming off the back of the last witness, which was the ARCHOs, and what makes a good block funding model, I suppose, and the capacity for localisation in terms of Indigenous, that's obvious. That has its obvious elements. But how do we design something that caters for the things that you were talking about, and also in circumstances where there might be a health professional operating in a practice providing a particular line of care but isn't catered for by the system at the moment? How do we build those sorts of things in, say, paramedics were talking to us in Brisbane last week about what their role, but there's nothing in Medicare in the MBS system that covers off for them. But how do we build that into, say, perhaps in a regional sense for a practice out? They're making a contribution to delivery of care, but also having that recognised as part of the funding model.
Yeah, so there's a few chains there. I mean, the ARCHOs often, I'm glad they spoke to you, are often a great example of multidisciplinary care in practice. Yep. Also an example of where the funding still matters. We are hearing increasing stories from ARCHOs that the complexity of multiple grant rounds, yep, sometimes many hundreds per year, and the sustainability of their funding is limiting their ability to provide that best practice comprehensive care that they're known for. Yep. But I think really a voice to listen to in terms of what can work, and shows that it doesn't all need to be Medicare fee for service. So we hear lots of calls, particularly from allied health and other professionals, wanting to work in teams, but thinking the only way there is through more Medicare codes, more MBS, whereas our view is both from local evidence but also international evidence that you sometimes do need a blended funding model, so that the team can genuinely work collaboratively together and not have to see each individual patient multiple times to sort of check the ticket along the way for funding models to work. So that's the type of work that has gone into the primary care task force following the scope of practice review, after hours, incentive payments reviews that have all happened in primary care over the past 4 years or so. And in our view, the starting point is to increase the WIP. It's a known entity that people understand, and so increasing that workforce incentive payment and broadening it to the types of health professionals that could be engaged under that. Of course, you'd need to make sure there was adequate acquittal of that and demonstrating that people were using their team. and then right through to more blended options where more of the practice revenue was block funded. But obviously that's got to be an opt-in situation. We do think there are practices that are ready for it, both in metropolitan and in regional, where they're keen to have a team that is block funded, but that's not an option at the moment. So that's what we've been working with government on is, okay, how could we build some of those options in?
Yep. So effectively not the reliance of the viability of the practice doesn't hang on just revenue from GP billings.
Exactly. Because at the moment that is the case. From a community private practice perspective, it is the GP billings that keep things going, which puts a lot of pressure not just on those GPs. It makes it very hard to step away and do that team-based clinical governance type work, team meetings, practice meetings, when the way that the doors stay open is the patient sitting in front of you, and it also makes it difficult to engage other allied health even where there's a clear need based on your patient population. The other thing to mention, My Medicare, so the endeavours, the introduction by government of My Medicare should be an excellent platform to start some of this work. Once you can identify your patient population, you know what their health factors are. Say you've got stacks of diabetes in your patient population, you go, well, maybe we need a diabetes educator. But we really need to mature that system and give it the love and attention it deserves to be a building block of a strong general practice sector.
I think you've given me an opening for the next segue, which is into the IT systems that support the whole structure. And we've heard a couple of times today about, let's just say, the age of the system and how it therefore doesn't provide us what it could or should provide us in terms of supporting the delivery of health services. Would you agree with the fact that there's some work to do to bring it up to where it needs to be so that it can actually effectively do some of the things that we've just been talking about?
Definitely. And again, a few different factors there. That there's two main software providers in general practice, and those have largely had the same interface, the same kind of product for as long as I've worked and long before that, so a good couple of decades. The government and the Australian Digital Health Agency, I'll declare I'm on the board of the Australian Digital Health Agency as a personal role, but have been working on better interoperability and obviously significant improvements to the My Health record. I can say from practice that things like the share by default legislation that came through in the past year or so has improved the visibility of things like test results and X-ray results, regardless of where the patient is seen. And I understand that government's next steps are to improve the visibility of medicines and some of the shared condition management plans, sort of chronic care plans and things. But a significant barrier to that still is that software interoperability alongside the workflow and funding. How do you get a team of people to all contribute to the same document, and as well as the patient obviously understanding what's happening there? So this will take, from an AMA perspective, we are strong supporters of better interoperability, smoother workflows, and reducing the number of clicks, but optimising care for patients so that they do have access to their healthcare information and can contribute to it, and as well as the rest of their healthcare team.
Does that include engaging into and with the hospital systems and the information that's involved there too? It does layer up a bit of complexity with the different health systems that the various states might be using, but the capacity of everything to talk to each other really does underpin the capacity to deliver care in a more informed way, if I could put it that way.
You need to be able to see patient health information in near real time as and when it's needed, and that's really variable across the country. For example, here in Queensland, I can access limited hospital-based information through the Queensland Health Viewer as a GP. but it's another whole system to log into, another set of passwords, another web portal. And in other states, a similar thing doesn't exist. So there is complete, GPs can't see into the hospital health system at all, other than what happens to get shared to My Health Record. So again, there's work underway through the Health Connect Australia, which is the national sort of interoperability pathway that's being invested in. But as a clinician, it can't happen fast enough. And that interoperability is important, as is that user interface when it comes to trying to see people as quickly as we can, to address some of the earlier questions. It's amazing. Today, writing a script, have to log into 3 separate systems to write one prescription is a barrier to providing high quality, safe, but efficient and speedy care.
So does that lack of visibility work from the practice to the hospital system work back the other way? That lack of visibility?
Yeah, they can't see anything of us other than the only thing hospitals can see of what general practice has done is now through the share by default system. They'll be able to see pathology and imaging results, but they've got very limited visibility and whatever shared health summary might be on My Health Record, but they've got no visibility into general practice systems, which tend to be hosted on on-premises servers.
I think that nearly covers me. I was just thinking about what else goes back out into the regional stuff, but I think I've covered what I want to do there.
Okay, we are done. Thank you very much, Doctor. Thank you for your time. I take anything on notice, please, by the 11th of September, but I don't think you did. But no, thank you very much, and we'll have another short break, and we will resume at 3-ish. Thank you very much.
Thanks for your time.
happily uninformed or uninformed.
I now welcome Representative of the Department of Health. Thank you for coming in sooner. Thank you for your flexibility. We were going to offer online to get you here, but we heard you're already in the car, so thank you. Senators resolve that an officer of the Department of the Commonwealth or of State shall not be asked to give opinions on a matter of policy and shall be given reasonable opportunity to refer questions asked of the officer to superior officers or a minister. The resolution does not preclude questions asking for explanations of how policies or factual questions about when and how policies were adopted. I understand that information on parliamentary privilege and protection of witnesses giving estimates or giving evidence to Senate committees has been provided. Correct? Is that right? Yep, done. For the Hansard record, starting at the left, can we please have our full names and the capacity in which you appear today?
Melinda Turner. I'm the First Assistant Secretary of the First Nations Health Division at the Department.
Sean Lane. I'm an Assistant Secretary in Workforce Division, looking after rural and First Nations workforce.
Louise Riley, Assistant Secretary of MBS Policy and Reviews Branch.
Jo de Rocha, Acting First Assistant Secretary for Primary Care Division.
Thank you very much. Do you have a opening statement?
Yes, if I can, Senator, very quickly. Look, obviously, thank you very much for the invitation to appear before the committee today. As you will see, our submission provides quite a lot of information across many areas of the department's responsibilities. My colleagues and I come from primary care, Medicare benefits, First Nations health and workforce. We'll do our best to answer questions that you have, but obviously there's a lot of expertise back in the department that we may need to go back to. We'll try and avoid taking questions on notice where we can, but it will appreciate that opportunity where we can't answer particularly quite detailed questions. So thank you.
Thank you very much.
Well, thanks, Chair. And I'm very, very mindful of the officers when you're being asked to take things on notice, and I don't want to do that to you, but if it makes it easier for you or you don't have the info, look, feel free, please. So can you tell us what are the bulk billing trends we're seeing across rural, regional and remote areas since the government's latest investments in Medicare?
Senator, I'll take that one. Thank you. So I have with me figures. We usually, because of seasonal differences in bulk billing rates, we compare, the most recent quarter to the same quarter last year. And so for, if we look at, I'll start with MMM2. In the April to June quarter in 25, it was 78.1. It has increased by 6.8% to 84.9. In MMM3, it has increased from 82% to 88.3%, which is an increase of 6.3.
Good.
In MMM4, we've seen an increase from 83.0% to 88.3%, an increase of 5.3%. In MMM5, from 82.7% to 89.1%, increase of 6.4%. And MMM6 from 79.7 to 86.3, an increase of 6.6%. And then in MMM7, our most very remote communities, we've seen an increase from 90.4% to 93.7, which is an increase of 3.3%.
Very encouraging.
4.9% nationally.
Very good, thank you. So what supports are available for a practice to determine whether they would be better off joining the BBPIP program?
Thank you, Senator. There's a range of supports available. Prior to the implementation of the program on the 1st of November last year, the department released a calculator on our website which was available to both practices and providers, and we also provided support through contracted parties that were partners to us, the Australian Association of Practice Managers, our PHN network, NACHO, to provide forums to assist practices and providers and point out the calculator so that they could have a look at whether it would be in their interest to sign up, noting that it's a voluntary program, and to calculate, depending upon their own specific details for practices and providers in their business, or to use models based on MMM regions and where they're located to anticipate what would happen if they were to switch to the bulk billing practice incentive program based on their existing data if they made no changes. Of course, many practices have decided to move from mixed billing to fully bulk billing as well. So I'm sure that calculator helped for those practices who are already better off, but there have also, as a result of all of the engagements, been practices who have chosen to make that move.
That's good. So we've seen a bit of traffic across the website, have we?
Substantial.
Very good. Tremendous. What telehealth supports are available for patients in these areas?
So, Senator, telehealth is available nationally to all patients. In terms of, we don't have anything specific for rural and regional communities. It's the policy settings that we have for telehealth are national settings.
Well, let me tell you, I'm excited about it because I actually used it in Kununurra a couple of weeks ago. So it was very, very, very welcome. Okay, so what are the benefits of... Sorry,
I was just going to add, Senator, one thing that we hope will improve access for people in regional and rural and remote communities is we've reintroduced what are known as patient end support items. So this is where a nurse practitioner or a GP or a practice nurse or an allied health professional, depending on who is at the other end, they're with the patient at one end and the patient is having a consultation with a provider via video at the other end. At the moment, GP support and nurse practitioner support patients to have video conferences with specialists, and from 1 March next year, practice nurses, allied health professionals, Aboriginal and Torres Strait Islander health workers and health practitioners will be able to support patients to have a consultation with their GP at the other end.
Oh, good. Very good. What are the benefits of patients joining My Medicare?
Continuity of care is the main benefit. So it seeks to assist patients to have continuous care by both providers and providers in a practice and to support that ongoing continuous care from a care team. There is also under My Medicare a general practice in aged care incentive which also practices care team arrangements and coordinated care.
Good, thank you. Now, I just want to ask around the single employer model. Got a couple of questions there, Chair. Could you walk the committee through the single employer model, please?
Yeah, so thank you, Senator. So the government is testing the single employer model, or SEM as we call it, through a series of trials to actually, and we have 12 operating across 7 jurisdictions.
12,
yeah, 12 sites operating across 7 jurisdictions, or have plans to, across MMs 2 through to 7. These trials will run through to December 2028. The actual SEM, though, whilst obviously it's an important trial, we need to consider that it's part of a broader series of measures that we've got as part of workforce to strengthen the medical workforce. And these include strengthening actual GPs numbers, but also rural generalist training places and also the National Rural Generalist Pathway.
And can you share with us the jurisdictions, the 7?
Yes, I can. So Victoria, we have 3 sites, so Gippsland in the Grampians and Loddon Mallee regions. We have in New South Wales, we have the Far West, the Illawarra, the Shoalhaven, the Murrumbidgee, Southern and Western local health districts, the Hunter, New England, Mid North Coast and Northern local health districts. In Queensland, we have the Northern Region, Central Region, Southern Region and Charleville. And I would just like to point out for Charleville, it's a First Nations-led trial delivered by the Queensland Aboriginal and Torres Strait Islander Health Council in partnership with Charleville and Western Areas Aboriginal and Torres Strait Islander community. In South Australia, there's the Riverland Mallee Coorong Local Health Network and also the Barossa Hills, Eyre and Far North Flinders and Upper North, York and Northern areas, Limestone Coast. Northern Territory trial will be in the Katherine and Big Rivers region, commencing in 2026, so shortly. And WA will also commence in second half of 2026 with an initial uptake of 20 rural generalist trainers.
Where in WA?
Sorry, I haven't got that one down.
See, I was listening. All right, okay. All right, that's no worries. I'm sure you'll let us know.
Yep.
So have you received any feedback from participants?
So the actual evaluation is a really important component of the trial, and we do have actual evaluation framework that's established. We've recently got some initial findings from that, so very timely. Since its inception, we've had 168 registrars that have participated in the SEM trials, and so this is as of October 2025, I should say.
Sure. Okay.
86% are rural generalists and 14 are general practice registrars. 66 of SEM registrars are based in modified Monash areas 4 to 7 practices. 63% are female, which is slightly higher than the broader registrar population of 54%. And of the 40 doctors who have exited SEM, 87% continue to practice rurally, 26 have achieved fellowship, 31% moved to fee-for-service and 21% have relocated. So what we're seeing is increases to early training appeal by reducing the financial uncertainty and simplifying the actual operating environment. It supports short to medium term retention of registrars in rural and remote areas, and we're also seeing some emerging benefits for hospital primary care integration and improved continuity of care.
Good, thank you for that. Are there any other programs that support primary care in thin markets?
Yes, there is, Senator. So what we do have is what we call the General Practice Incentive Fund, and it's also known more broadly as the Thin Markets Program. So what that program is designed to support primary health networks to implement place-based solutions. So it's really looking and getting under the hood, really, in terms of what's needed to improve the delivery of primary care services in regional areas. Government's committed approximately $50 million over 5 years for this particular program. And what it does is, so it directly funds the PHNs to come up with what we call a service system recovery plan. And that actually works with local health providers, works with the state government health departments and agencies as well, to actually come up with a plan over a 3 to 4 month period. And then once the department has assessed that plan and accepts that plan, is we then fund the implementation over an 18-month-ish period.
Yep.
So those plans, importantly, are co-designed with local communities. We have a number of sites across the country, and I can give those to you if you're interested, if that would help.
Yeah. I'm sure the committee would be.
Yeah. So we have 3 sites in New South Wales at the moment, so Canowindra, Clarence Valley and Murrumbidgee. In Northern Territory, we have Berry Springs and Nullumboy. In Queensland, we also have 2 sites, the Cassowary Coast and Dysart. In Tasmania, we have 3 sites, so Huon Valley, Central Highlands and West Coast. And in Victoria, we have Swan Hill, Stanhope in the Rochester area, and East Wimmera. And in Western Australia, we have Kununurra and Newman.
Fantastic.
Yeah.
Very good. Happy to hear that. Now, just I want to go to workforce supply and a chair I'm flying through. This is great, mate. I won't be long. Workforce supply, if I could. So could the department explain any investments in supporting Aboriginal and Torres Strait Islander communities to access healthcare?
Thank you, Senator. I'll start, but if anyone else wants to jump in.
The floor's yours, Ms Turner. Don't give it up.
We fund Aboriginal community-controlled health organisations to deliver healthcare in a range of communities. So we fund around 123 organisations at the moment. Yep. The way that the sector operates is we have what we call a Section 19(2), which means that the ARCHOs can access Medicare and claim Medicare under the 19(2). We also fund them through the Indigenous Australians Health Program, through what we call comprehensive primary health care. So it is a blended model that enables them to provide a multidisciplinary care approach to their patients. And that's how the delivery works through the Aboriginal community-controlled health organisations.
Great, tremendous. Did anyone else want to add anything? No, that's good. Okay, and can you explain the work that rural workforce agencies do? I've got a bit of a stutter up there. Sorry about that.
Yes, so thank you, Senator. So the rural workforce agencies are funded through the Australian government as well, and their role is primarily to work with service providers in rural, remote and regional areas, but also in MM1 areas where they're designated as a DPA, so where there are identified service challenges, and they work with those providers to assist address workforce challenges, really. So they facilitate access to a number of workforce programs that the government offers, and part of that is international medical graduates as well that come in and join the workforce in Australia and are required to work in regional areas.
Okay, we've got any numbers of how many workers or GPs they've helped to recruit?
I don't have that. I am happy to take that.
Geez, we really thought we were going to have 100% record then.
Yep.
That's no worries. Well, that's one. Unfortunately, you'll have to take on those who've got that info. Thanks very much. Now, workforce training. If I could just go to questions there, if you could just walk us through the investments the government's making in training the health workforce in rural areas.
So thank you, Senator. I'm going to talk more broadly about the training programs. So there's a number of training programs that the Australian government supports. Some of those are targeted specifically for rural and regional areas, and some have specific quotas as well. We, in over 4 years from 25-26, so the investment's in the order of $660 million, and that's really to increase GP and rural generalist training pipeline. So I'm only talking GPs here.
Yep.
So I can list through the number of programs if.
No, feel free.
Yeah. So the Australian
my chair's being very generous with the time.
Okay.
But,
so the Australian General Practice Training, Regional Generalist Training Scheme and Remote Vocational Training Scheme. So that provides fully funded training for more than 5,000 GP trainees through the Australian General Practice Training, or AGPT program, and I saw earlier there was references to that program. Also the Rural Generalist Training Scheme and the Remote Vocational Training Scheme. So we've had more than 1,800 junior doctors commence fellowship training in 2025, and that's the largest cohort on record.
Oh, that's good.
And around 50% of those government-funded GP training occurs in regional and rural areas, which are MM7, 2 to 7.
Great. Look, that is very encouraging.
Yep.
Thank you for that.
There are others as well. I can go.
Keep going.
Yeah, okay.
Until he starts growling. So if you're getting
okay, well, feel free to cut me off if you like. So there's also further investment to extend the pre-fellowship program. So there was $18.7 million over 2 years, and that supports non-vocationally registered doctors to gain general practice experience and increase access to primary care in areas of need. We have our bonded medical program. So that provides Commonwealth-supported places in medical courses at Australian universities. In exchange, participants complete a return of service obligation, working for 156 weeks as a medical practitioner in regional, rural and remote communities. And that supports approximately 900 new medical students each year. And as at the 2nd of January this year, there were 17,000 participants. We also have the Higher Education Loan Program, so that encourages eligible doctors and nurse practitioners, I will add that one's nurse practitioners, to reside and work in rural, remote and very remote Australia. In return, the Australian Government offers to reduce or waiver in full help debts for eligible courses, and also waives the indexation on outstanding help debts. We have the Rural Health Multidisciplinary Training Program and the Murray-Darling Medical Schools Network. So that's investing in training and education initiatives. Over $1.1 billion investment between 22-23 to 26-27 to support rural clinical placements and education through the Rural Health Multidisciplinary Training Program. And the Murray-Darling Medical Schools Training. These fund 23 universities to deliver training places, rural training experiences, and so it supports rural clinical schools, university departments of rural health and regional training hubs. The Rural Medical Commonwealth supported places, the government has expanded Rural Medical Commonwealth supported places, adding 140 new rurally based places since 22-23, and up to 100 additional places commencing in 26 to strengthen the future GP and primary care pipeline. Up to 80 of these additional places are based in rural and regional locations. The Junior Doctor Training Program, so there's a private health stream with that. That supports junior doctors in postgraduate years 1 to 3, train in private hospitals, requiring at least one rural rotation. We're investing more than $200 million over 4 years in rural primary care rotations for pre-vocational doctors, and that supports 1,000 rural rotations annually from 2026. The Australian General Practice or AGPT program remote vocational training scheme includes a further investment of more than $600 million over 4 years to build the GP workforce, including through rural pathways. And that program requires half of all training to occur in MMs 2 through 7 regions as well.
Well,
I think I can have a breath now.
There's no moss growing below those feet. All right, thanks. And Chair, my last batch of questions. Can you tell us how has the government invested in the general practice workforce of the future?
So, Senator, I think indicating in terms of those programs, I think that's
covered. There's nothing else there.
Probably in terms of a good investment.
I thought that as I asked it.
No, that's okay. But I think the important thing is that we're looking at this workforce as a key enabler in terms of delivering primary healthcare services to rural and regional areas. So whilst the workforces are very important and we're investing a lot in that space, there's a lot of other enablers within the system to improve the delivery and access of health services in rural areas.
Okie dokie. So what is the Australian Primary Care Pre-Vocational Program? And what benefits does it deliver in regional and remote areas?
I could, if you give me a few minutes, I could probably find some information on that.
While you're digging around, that's all right. No, if you're digging around, I'll move on to another couple of questions. But if it's all in your area, we'll have to come back to you. But how many additional medical CSPs has the government supported? Ms Turner, is that your area?
I don't know.
No, you just moved to throw me out?
I am just writing that down.
Okay, it's all in the same. All right, then, Chair.
So I can answer the CSP.
Ask me what a CSP is.
Question in Commonwealth supported places. So the government's expanded rural medical Commonwealth supported places. We've added 140 new rurally based places since 22-23.
140?
Yeah, and up to 100 additional places commencing in 2026. Up to 80 of these additional places are based in rural and regional locations as well.
Okay, and how important have salary and leave incentives been for GP trainees, to your knowledge? Because we've heard about it earlier on.
There's a number of scholarship and grants programs in these supported places, obviously assists access in terms of as those training places are taken up.
Okay, and did you have that answer you were looking for?
So I haven't.
Because that's my last one. I'm finished. I'm done then, Chair. Mr Lane, you've been very, very efficient, as has everyone on the front.
I might have to, unfortunately, take that one on notice. Sorry, otherwise I will see if I can find it. If you've got other questions,
see if you can. So you don't have to go back and then send it back to us. That's fine.
Do my best.
Thank you, everyone. Thank you, Chair.
Look, I'll just ask one question before I send a copy. There's been lots of numbers and lots of things there. We're talking about, my count, 17 different funding programs. We're talking about 140 places in a program. We're talking about 650 million here, 18.7 million there, 5,000 GP places. We're talking about 900 medical students supported. Lots of numbers. But it doesn't get down to the core that there's still a 13-year life expectancy deficit in remote and very remote areas compared to metro ones. What, outside of these things, what are we monitoring that can close that? Because all of these programs by themselves haven't brought down that number. That number stayed stubbornly obstinate for a long time. What are we doing there?
I think, Senator, I've obviously given a lot of information on training programs. As I stated earlier, it's really, a system, everything coming together in terms of investments through Medicare, investments in primary care, investments in our First Nations health.
But closing the gap got worse in the report on this. On the closing the gap report, that was not improving. Yeah. I mean, that's my concern. Activity isn't productivity; it isn't outcomes. And I get there's a lot of activity. I get there's a lot of fun. I don't have a problem with that. I'm not going to go against anything you've said. It just doesn't seem to be working.
I guess, Senator, it's also important to remember the social determinants of health.
Yep.
There are many levers or many supports or programs or investments that have to be done across many portfolios to help with this.
Okay, thanks, Senator Colbeck.
Thanks, Chair. You've just talked about a lot of programs, and I suppose one of the things that's come through in the conversations with the ACHOs, for example, but also other regional communities, and the system only measures what the system delivers, and in some places the discussion and some of the evidence that we've received is, I mean, there is no MBS or no Medicare system in the area, so you can't measure what's not delivered. How do you bring all of this together? And even the ACHOs earlier today were talking about how many different programs they have to apply to design something that makes one efficient service. And to the extent where sometimes the administrative burden is almost too much for what they receive out of the system. I mean, and what I'm looking to see out of this is how you actually design something that works for the communities who are just wanting to receive care, and a system that delivers that. The ACHO system is probably a decent model, but still complicated by so many different funding streams that it doesn't. It sort of gets there, but there's still a whole heap of complication in there that doesn't need to be. How do we change the way the system's structured to build a model that actually can work and take into account the different elements that are specific to communities?
Yeah, I'll take that one. Particularly in regards to the ACHO sector, we are working very closely with the sector, so ACHO is the national body, but also down at the, particularly, in our remote areas as well, on how we can streamline a lot of those funding agreements that we have in place, but also measure the impact that they're having on the ground. I think particularly when I look at our funding within the Indigenous Australians Health Program and that funding that is allocated to the ACHOs, we need to do things differently. As Senator Cadell rightly pointed out, what we're doing hasn't been working, and so we do need to change the way that we're doing it. And that includes looking at the funding formula that we use for remote and regional and very remote areas, and making sure that we are addressing the need within those communities. And so we are currently working with the sector on that and how we go about doing that. It is, particularly in the Northern Territory, we've had a big focus on the workforce and how we actually look at increasing that workforce, utilising different mechanisms that we have available to us. And I think one of the most successful programs we've had has been the 500 Trainees program, where we've had exactly that, more than 500 now, go through that program that NACHO have run, which has enabled the system to grow that little bit more. We recognise that there is a lot more to do, and so we are focused on working on that and making that happen. But particularly in our remote and regional areas, it is, it is a concern, and we know that we need to do things a lot differently in order to address that specific need. I think going back to with the social determinants of health and working across other either federal government departments or down at the state and territory level as well. So we need to bring that together. Often, sometimes that is a bit, doesn't quite work together. And so we are working a lot more closely with our state and territory organisations to work closely on that as well. I don't know if you guys want to add anything.
I don't think I have anything really to add. So we obviously recognise in terms of there are, in the workforce space, there are a range of programs, and you've heard about some of them today. We are continue to look at ways of streamlining, bringing together, drawing efficiencies in those programs, and look for the appropriate time to do those things.
Well, what work's going into the actual adequate compensation or payment for the delivery of services and the non-recognition of some elements of care that mean that a business model doesn't stack up. So, and we've heard this in so many different places. We heard from the paramedics, for example, that there's no recognition of their profession and the care that they can provide in service delivery. I've been to a practice where there's a paramedic but there's no support for the service that's provided in that. We heard from Queensland Health that the MBS items probably cover about 75% of the cost of delivery of service in those shared facilities that are operating in Western Queensland PHN area, and some places where local government, for example, is investing an enormous amount of money just to ensure, in say, providing the facilities or housing or something like that, to ensure that there's actually a service there. How are we looking at programs that are actually going to provide service delivery in places where there isn't? And there needs to be. Some of them are sparse. I think we were talking about one in Queensland. There's 1,200 people over.
Yeah,
what was the area?
1 million square kilometres that has no GPs.
And so that, I mean, look, they're difficult. We get that. But how do we recognise or design or simplify our programs, particularly the possibility of block funding that will recognise the core elements of delivery of service, rather than the hugely fragmented type of funding that we currently have for the RCHOs. I mean, I recognise what you've already said on that. But
Senator, as you know, there's been a number of reviews that have recommended block funding or blended funding payments, and the department put together a task force that sat for about a year and a half, and that's just concluded at the end of this financial year, and advice from the task force is being considered.
Can I just go back to the program that's the General Practice Incentive Fund? What's the criteria for choosing locations for that? How is that? How do you qualify for that?
Yeah, thank you, Senator. So it is a program that is a terminating program, so it's not ongoing funding. What we are looking at, so we look where there's opportunities to work with local communities to actually implement a place-based solution.
When does it finish?
Through to 2027-28, I think, is the final year. So it's 4 years from 23-24.
Okay, right.
So what the actual funding provides, and maybe it might not be answering exactly what you're looking for, Senator, but it's actually working with the stakeholders and community engagement to co-design and deliver actual activities. The costs that provides funding for the stakeholder consultation, also who actually build that service system recovery plan. It is actually what we actually want is a solution that can be funded within that period, and then that becomes a sustainable solution moving forward. So it's not designed for where there is a thin market that needs ongoing interventions or ongoing funding. So it is very much looking at identifying what the problems are, what the challenges are, whether primarily a workforce lens, and then implementing those types of solutions. So, and there might be some innovative solutions that come up and work through with the community, alternatives, interim service providers, allowing for recruitment of other workforce for long-term solutions.
So the concept is that it becomes, that the practice that it's supporting becomes self-sustaining, doesn't need any other support.
Outside of what normal supports are available. So there's a range of supports that are provided in terms of through primary care and Medicare benefits, etc. So what that's looking for is putting that injection into that local solution to actually deliver an ongoing sustainable solution.
So if part of what the community come up with as far as what they need is something that's not supported by the Medicare or the funding system, then that has a life which is effectively the same life as the program.
That's correct. So it is short-term funding of 18 months to 2 years. So that's the period that we're looking for to to get a solution implemented. So if there are broader issues at play and that can't be resolved through this particular program, then that wouldn't be something that would be looked at funding.
Okay. So how are the particular? You said in Tassie it was Huon, West Coast and Flinders, was it?
So in Tasmania, Huon Valley, and then the Central Highlands and the West Coast.
Central Highlands.
And they're the two that have just recently been funded.
Just a hand from any, so there's Canowindra, not Canowindra. In New South Wales.
Canowindra.
Canowindra.
Did I say Canowindra? I'm sorry.
No, you said
did I? Canowindra. I'm from WA. I'm sorry. There's some challenging terminology in WA. It doesn't translate to the East Coast very well.
Local knowledge is a big deal. Okay. All right. So how were those locations chosen?
Yes. So really we asked the primary health networks to look at particular service challenges within their areas, working with the relevant state and territory governments, and to work in partnership. So really it's not really the Australian government provides the funding, but it is locally driven in terms of bringing forward sites. And as they've, and we work in partnership with the primary healthcare networks to work through is that site going to be funded, eligible to be funded through the Thin Markets program.
So is there any process where you learn something about those locations and determine as a part of that process that they're going to need something ongoing, and then that's a consideration post this? I mean, are we learning something out of this? I mean, yes. I know all of those locations, the West Coast, I was down the Huon last week, Central Highlands. I mean, all of those have their challenges, but my sense would be that those challenges aren't going to go away from a temporary program. That the challenges will remain afterwards. So what happens after that? Even in terms of within the region, why pick one practice and not others? Because what I'm struggling is, why is the Commonwealth funding some things in some of those locations and not others? And so Central Highlands, I'm sure, are funding accommodation for doctors, for example. It's part of the cost of delivery of service. I think Circular Head, St Helens are doing the same thing. I'm just waiting for the data to come to me on those sorts of things. But primary care is of Commonwealth responsibility, and yet other levels of government are funding so much to actually make sure that there's actually delivery there. And what we're looking at here is what is a sustainable model that the Commonwealth appropriately takes responsibility for in terms of delivery of the service.
I've probably been remiss in the one of the key outcomes from the General Practice Incentive Fund or the Thin Markets program is taking those learnings. So whilst it is a discrete program, so part of the criteria is that a service system recovery plan must be able to deliver a solution within the 18-month window. Except it's not a silver bullet. It won't solve every, and the funding is not there. It's not designed to, fund every thin market. But what we do is we work with the PHNs and the relevant state agency to identify priority areas that they've indicated that actually the Thin Markets program would be beneficial.
So what if at the end of the program the business that's being supported or the practice that's being supported still isn't sustainable? What happens then?
Well, we haven't had that just yet. But
you haven't got
it's one of the
program,
risks that's being managed. So one of the risks that's being managed within the program, and part of working through and building a system recovery plan is to actually give us confidence that it will deliver a sustainable solution.
Okay, so then I'm treading on the concept of what ifs, and I'm not allowed to talk about what ifs. Hypotheticals.
No, hypothetical. It's not Jeffrey Robinson's.
So do you actually measure how much, for example, local government is contributing into the system to ensure delivery of care in their locality?
So it's going outside of my area of expertise, and people probably at this table.
I reckon you're all probably going to look up and down the table on this one.
But I can say, so we did appear before a committee yesterday which was looking at the federal financial relations with local governments, and that issue in terms of local governments investing in delivery of health services is being investigated through that committee. We don't actually have a mechanism to capture what might be spent by other areas of government in the delivery of health services. So we know that the Commonwealth makes an investment, states and territories provide an investment, and there are others individuals provide.
I guess noting that state and territory governments have responsibilities under the National Health Reform Agreement to report on their spending or their activity in public hospitals.
Yes, but it's not primary health.
No.
We're talking primary health here, and primary health is a Commonwealth responsibility. So that's what I'm trying to get a sense of. As a part of the state's reporting, do they report what their contributions are in supporting primary health?
That's something I would have to take on notice, Senator.
Okay, well, I'd be interested if you'd taken on notice whether they do, and then if there's any data, I'd be interested in understanding what those numbers are for each of the states and territories. I was thinking back to the evidence that we got in Brisbane a couple of weeks ago, where Queensland Health talked about some of their practices in regional Queensland, where the MBS system provided, I think the number was 75% of what their overall cost of delivery of service was. I think they're coming back to us with some numbers on that, but I'm curious as to the quantum of what that might be. I'm aware of the tension between various levels of government on cost shifting, but particularly concerned about it from a local government perspective, and I have asked local government to see if they can give us some idea, this committee, some idea of what they're spending, and if there's a process going through another committee, I'm sure they're working on the data, but I think important for us to understand, and important for the Commonwealth to understand in setting policy as to how they might appropriately compensate the system for delivery of primary care. We've had a bit of evidence today in terms of the design of the system in terms of information flows from between various elements of the health system in the service provision, and the conversation is that the back end of some of the Commonwealth system is fairly old and not compatible with easy information flows. Have you got any information that you can give us on that?
Senator, that'd unfortunately we'd need one of our digital health colleagues, I suspect, to be here. There is a lot of work happening in terms of setting standards to ensure that the same information is captured in various settings so it is shared more easily. And I'm sure you're aware there's also a lot of work happening around My Health Record and ensuring that providers and patients can access more information through there. But unfortunately, it's not in my responsibility, so I don't have a detailed knowledge of it.
So there's a lot of concern about the fact that inhibits the capacity of the system for delivery and efficient delivery of service. So perhaps if you could take on notice to give us some advice on what's going on there so that we can adequately reflect that in what we say as we work through our reporting process on this, because I think that's important. Also, in terms of what's being measured, so when we were talking to the Australian Institute of Health and Welfare earlier about what they measure in terms of the data that they get, a lot of that comes from the system. Is there any work being done on getting better information on what's actually delivered and within the system, or is that in the same realm as we've just been talking about?
Again, Senator, I can talk a little bit to this and we can provide more information on notice, but certainly there is work happening around things like, for example, in a GP consultation, we don't have reliable, like we know that a consultation was claimed through the MBS, by that provider for that patient, but we don't know what happened in that consultation. And while, allowing for privacy concerns and everything else, there is work happening around getting information like essentially, I'm not sure of the number, but, obvious reason for attendance. Was it about cardiovascular health, or was it about, mental health, or,
So that would go to the improvements being made in the back end of the system as well?
Yes. So we can capture reason for attendance, for example, and know more about what's happening while respecting appropriate privacy considerations.
Archo's talked to us about the Indigenous health services, actually more broadly, and in the submission talked about registration at multiple practices as part of the system and the restriction that placed on service delivery because of mobility. And interestingly, a submission that we received this week from Motherland talks about continuity of care and same clinician. And they said, from a rural perspective, the evidence from a recent piece of survey work that they've done, continuity of care, the same clinician more than once was repeatedly described as a rural privilege rather than a baseline expectation, which I thought was a... So how do you manage, or how can we look at making the system work better for those communities where that is a problem? So you've got the Indigenous communities are all saying it's an issue because largely of mobility. You have to register with one practice and that's where it goes. And similar sorts of things coming from other communities. This is basically focused on women and services that they receive. Do you have any thoughts on that?
So in relation to My Medicare, where a practice registers for My Medicare and their patients register, there is a hub and spoke model for the Archo sector that allows allows a patient to move between hubs and spokes, if you like. So it's a little bit different to the My Medicare registration outside of that sector, and provides a little bit more flexibility. But we certainly have heard from the ACHO sector that they would like to see further improvements to the system to allow for additional practices to be registered to support that, support movement, if you like.
Yes, they're saying free, aren't they?
Yeah.
Yeah, that's certainly the evidence to all the submissions to this committee. I mean, I suppose that's effectively going to be a policy decision for government?
Yes.
Okay, I thought I'd get that answer. I mean, but what about other rural service receivers? I mean, I'd recommend the survey work from Motherland to you. It's quite interesting. It'll be more formal. More of it will be tabled in a few weeks. But how do we manage those others that are having the same sorts of issues? I mean, we're talking about perhaps looking at a model, or perhaps I should say we're considering looking at a model in this committee for rural practices or regional remote practices that looks a bit more like what the NACHO sector does, which is why I'm interested in simplifying it. Mm-hmm. But we have similar issues for those people in those communities.
Certainly we've been listening to feedback. We're always trying to make modifications to the system where we can. Certainly within my delegation and within my budget, I make modifications where possible, but where it requires decision of government and where it's a more costly process to change the system, we're collating that advice and we'll look to provide advice to government in due course. There is probably less advocacy, more advocacy from the ACHO sector around the additional practices, but we certainly have heard in other areas that people would like additional practices attached to My Medicare.
I'm going to get into trouble for policy areas, so I'm going to have to...
Give it a go. They can only say no. Miss 100% of the shots you don't take.
They won't say no to me. They'll say that it's a matter for government. So
well, now you've given them the out.
No, if you know the answer, don't ask the question.
I'm not going to. Well, no, they're the best questions to ask.
I always told them, don't ask me questions.
Always ask questions you know the answer to. Yeah.
You good?
I think I've covered most of it.
So,
I mean, I will go to one. I mean, so practices where there are allied health services being provided within a practice that aren't currently recognised into the system, is it, but make a fundamental contribution to the viability of the practice. I mean, bundling some of these services together so that it actually does create a viable business, if you like, because that's what a lot of the regional businesses are. I mean, how do we design those things into the way the system works? It might be a paramedic, and paramedics, as we heard in Brisbane, aren't covered at all by the system. Restrictions on nurse practitioners. Is that something that's potentially covered by the scope of practice work that's being done at the moment, so that those can be brought in, contribute to service delivery, and therefore the reality of a service being actually available in a community?
So, Senator, I talked earlier in my evidence about the general practice in aged care incentive, and that incentive provides support for residents in aged care homes to receive quality continuity care from team-based care. So it certainly allows alternative providers to provide some of the services, whether they're a nurse practitioner or a Aboriginal community health worker. That being said, I hear what you're saying.
So the concept exists,
yes,
but
there is certainly, we are receiving lots of feedback from the sector that they would like to be fairly remunerated for the provision of more team-based care and more multidisciplinary care, and that goes to those recommendations that were given to government and to the work of the task force that I mentioned before that has just recently wound up, and we're considering the advice at the moment.
Okay, all right. I surrender.
Well done. Well, that concludes. Thank you for your evidence. Thank you here today. If you've taken things on notice, I think you did. Certainly one question. Can we have that by Friday the 11th of September, if that's possible?
That should be fine. I can give some information to answer one of them that I took on notice on the Australian Primary Care Pre-Vocational Program, which might make Senator still happy. If I can. Yes.
Go.
So some information on that, Senator. So it supports pre-vocational doctors to gain general practice experience through primary care rotations in rural locations. In terms of what this particular program will deliver in a rural context, so 1,000 rotations in rural locations MM2 to 7 from 2026 onwards. It will also provide and support rotations in metropolitan areas as well. Though it will continue to prioritise rural primary care rotations with over 70% of the 1,400 total rotations from 2028 to be delivered in rural locations.
There you go. Right. Thank you. Hello, we've opened a door, yes?
No, it's not related to that actually, but, well, it is a little bit perhaps. Did you do any measurement of the change in residential qualifications for GPs that were made probably 2023 around the MMM locations that they were registered to work in, and what impact that had on the more regional practices? And I'm thinking here of, I'll give you an example.
Yep.
The changes were made to the MMM locations, and so the GPs who were working down the Huon moved to Hobart because 2 came in, wasn't previously, and that meant a movement in practices had an impact on the practice clearly at the time. But so did you do any measurement of the impact of that?
Senator, I don't have any information on me. If you would like, I can.
I'd be curious to understand a couple of years down the track whether it's had an impact and how it's manifested.
We can take that on notice for you.
Yep. I'm going to try again. Thank you for the evidence you've given today. If you've taken any questions on notice, please don't answer them now. And I hope by Friday the 11th of September would be wonderful. And I now conclude today's hearing. Thank you to all witnesses who appeared. Thank you, hands out. Thank you, broadcasting. Thank you, Secretariat. Thank you, witnesses. Have a great day. Thank you, Senators.
Thank you very much.